Testing. It's a quick fix. That's a quick fix, right?
Yeah,
Theoretically.
I don't think it's going to be a problem, but
I don't see anybody taking up all the front row somewhere.
but
Might be nice though, right? How many do we have?
well,
Like blank
there's
paper,
up
I can
to
just write
5
reserved
at
on
a
it.
time.
A
Well,
very
they're all
clean
there
writing.
now. They took 4.
Oh.
And
Perfect.
that's the first set.
All right. Hello. Hi. Good morning.
Step on the sign language interpreter here.
Oh.
Are you two the first two speakers?
think they're gonna miss out.
I think so too.
Starting in a few.
We're starting now.
Oh, okay. Doors are closed. Are they gonna bring it out? It's up to you. We're the good guys. I'll have to take the house lights down a little bit.
Yeah, okay. So give me 2 minutes.
No, it's
By the
okay.
way, I really appreciate you taking the time of your business.
problem.
I really do.
No, I'm thrilled to
This
share
means
it,
a lot.
so it's all good.
You can keep chatting, just let me know. That's good. Good morning and welcome. My name is Angela Sharenza and I will be your moderator for today. Welcome to the Center for Medicare and Medicaid Services. Visitors must be escorted at all times when in CMS facilities, with the exception of this large conference facility, as well as the adjacent corridor, the CMS Conference Center, the first floor elevator banks, the grand staircase to the lower level leading to the cafeteria, and the cafeteria located on the ground floor of the central building. Please wear your visitor badge above the waist on the front torso in full view at all times. Access to CMS information technology systems is forbidden. During a fire evacuation or a shelter-in-place event, you will take direction from your host and/or escorts. In the event of a building evacuation, Assembly Area 19 in the CMS parking lot has been designated as your assembly area. Evacuations will result in an accountability roll call prior to re-entry into this building. While the conference is in progress, please use the rear auditorium doors to enter and exit, and mute mobile devices or set them to vibrate. I'll provide reminders on that throughout the day after breaks, so on and so forth. We've found that the noise from the exhibitor areas often carries even with the auditorium doors closed, so please be aware of your conversation volumes as you're speaking with the vendors outside. We will break for lunch at about 11:35, and then the conference will resume again back at 1 o'clock. Restrooms are located in the hallway just outside the exhibitor area to the left, and there are also refreshments available in those areas. Please note that the exhibitors are very excited to talk to you about their capabilities. We encourage you to visit the exhibitor areas throughout the day, during breaks, at lunch, and after this afternoon's Executive Roundtable. Another note, questions will be taken through WUFU's online submission at the URL referenced around the room. You'll also see it on the screen here as well as the doors. There are little posters that have a large question mark. You'll see those scattered throughout the room. For those of you here in the room, please take note of that as well as those of you joining remotely. Please also note that the URL begins with HTTPS. That S at the end is very important, otherwise you won't be able to access that link. I'd like to thank you all for your cooperation. I hope you enjoy the day very much. And without further ado, I'd like to please welcome George Linares, the CMS Chief Technology Officer.
So, good morning, everyone, and welcome to Convergence 2018, our fourth annual IT conference. Before we get started, I really have to acknowledge all of the people really that came, that's put this event together, the participants, and there's a lot of teams that have converged together really to make this event happen. So I do want to say thank you. So Convergence, right, it's our fourth annual. We didn't know if it was going to last this long, but I'm very happy that we keep moving it. So Convergence really, it's a way to show how CMS is really connecting the dots across the agency while we're introducing new technologies. There's always the question, are we introducing technologies? We are today. So this is a way to demonstrate that innovation is really happening across the agency from every corner. It's not one component. It's all of us. And the great thing is that it takes all of us to move CMS's IT ahead. Another key factor here, it's important to note, is CMS's leadership, their engagement. They are a key force really to move IT, the direction and influence how IT gets implemented at CMS. So what we have done today is we've formed the IT Alliance. You've probably heard of the IT Alliance. The IT Alliance is composed of the senior and executive IT leaders from across the agency, and we're all coming together really to address those IT challenges that CMS has, to remove those barriers, and continually forging ahead CMS's IT strategy in trying to support our business, because at the end of the day, it's all about the business, right? So when we're thinking about IT, it's about the value. What is the value of IT? Is to make things easier for the user, for the customer, whether it's internal, whether it's external. So the true value of IT really is fully realized when that engagement with the customer, the interaction is a critical part of the overall offering delivery of IT. So making it so technology is great in itself, trying to innovate, bringing the new toys into the environment, but making sure that we have the added element of making sure that we're very thoughtful around engaging the customer on how we offer those services to them is also just as critical. The other piece around value is cost, and we can't get away from it, right? So all of us, we're always looking for the best value of government. We're the best value that we can, solutions, offerings, technologies, services. But also, all of you here, can play a role trying to identify and seek, opportunities where we can sort of do some cost savings, some cost avoidance, because those opportunities really open the door for other endeavors across the agency where we can innovate, we can modernize. So at the end of the day, it takes all of us to hopefully move CMS's IT to support all of their programs. And you'll hear these thoughts sprinkle across the different presentations that we have. So with that, I think Angela already addressed WUFU. I encourage you all to please participate, submit your questions. And with that, what a better way to get things started than with our keynote speaker. So I have the great honor to introduce CMS's Principal Deputy Administrator for Operations, Kim Brandt.
I was pulling up to CMS and I thought, my goodness, why are all these cars? And I remembered, oh, it's Convergence. All the cool tech people are here today. So it was very exciting to see all the people and to see everything going on. It's great to be here today because for me, it's really been fascinating. I've been back at CMS now a year this week. And as many of you know, I was here for 7 years before, back from 2004 to 2010. And it's been really interesting to see just how things have changed from a technology perspective. I mean, when I was here before, when I first started doing program integrity back in 2004, we didn't have an integrated data repository of any kind. Each of the individual MACs, some of which were still FIs at the times and carriers, had their own individual data repositories. There was no good way to look across data or to be able to run algorithms or to be able to look and see where we were having issues in our programs. We certainly weren't able to use the data to better drive our policies, to make decisions about beneficiaries and the different things that they need and how we could better provide those. And it's also been fascinating just to see the change in the work environment. Today we have, a full third of our workforce that works telework on a regular basis, many of them at least one day a week, some even more. That's exciting too. Before we didn't have that. It's great to be able to have hoteling stations here where people can come in when they need to, be able to dock in, dock out. But it's just been great to kind of see that evolution, if you will. It's also been great for me because I've actually gotten to learn more about technology. Thanks to George and Mark and Rajiv and others, I've actually become a bit of a techie over the past year. I got to go to HIMSS for the first time this March with the administrator. I went to Datapalooza, and then on Monday, many of you are aware, we're going to be hosting the first ever developer conference at the White House, showcasing a lot of the API work that a lot of our folks have been doing in conjunction with the Medicare Blue Button 2.0 initiative. So it's really exciting to see sort of the evolution of technology that has occurred. Certainly for me, from when I left to when I came back, but especially from when I started, way back in the day to now, it's great to see how CMS has evolved. But I think what's even more exciting is how much we're going to continue to evolve. And I think that's really what today is all about and what a lot of the conversations you're going to have are. One of the big goals of the administrator, of which she has a few key ones, is to drive more innovation, quality, and accessibility in healthcare. And along those lines, one of her big priorities is how we can leverage data better. What can we do to better be able to get data out in forms that people can use, whether you're a beneficiary, a researcher, or others? How can we get data out? But then how can we internally use our data better as well? And then also, I think along with that, we really want to be able to leverage technology in the best way possible so that we're preventing and detecting programmatic abuses. As you all know, program integrity and anti-fraud and abuse is near and dear to my heart. It's the issue that I probably focus on the most, and that is sort of, I started as a healthcare fraud prosecutor right out of law school before I came here to CMS, and I've never quite lost those prosecutorial roots in terms of wanting to go after the really bad guys who are taking advantage of our taxpayer dollars and also harming our beneficiaries. So it's really exciting to see the different ways in which we're not only focusing on better data quality, but also leveraging that technology so that we can do more. I know in the CPI space, one of the things that's been really awesome to watch is the evolution of the fraud prevention system and the different algorithms that they're using to be able to run against our now integrated data repositories, to be able to actually see where there are issues happening in the Medicare program. I personally was thrilled to see that we recently, if you aren't aware, hit our 50th state reporting in Medicaid data into the TMSIS program, which is also a really big deal because as we continue to improve the quality of that data, that's going to give us valuable information which eventually we can match with the Medicare information to really be able to look across the scope of the 72 million beneficiaries who are in those programs to really be able to figure out what's going on there and sort of across our whole 130 million beneficiaries total, sort of what's going on in both the programs and where it is that we see aberrancies and other types of things. I think also most of you have heard Secretary Azar and the administrator stress how they're really interested in value-based healthcare and how they really want to have better value in the healthcare setting. And so what'll be exciting is how we can use not only areas where we think that there need to be policy changes to avoid people taking advantage of the programs, but how we can also use that to create better value in the programs. What can we do? How can we use the data? How can we use technology to help us be able to figure out how we can provide better value in the healthcare programs? How can we provide care in a more accessible way that hopefully is of high quality but ultimately has lower costs? And how can we use technology to help us identify where those opportunities are and to be able to drive towards that? I know that many of you have seen Adam Buller, our new head of the Centers for Medicare and Medicaid Innovation, speak. He is definitely an innovator. He comes from the private sector, has been very involved in a lot of really tech-driven healthcare ventures, and he is a big advocate for how technology can really help us to be able to make meaningful changes in healthcare. And I'm excited to see how he, in conjunction with the administrator and the secretary, will really help us drive towards that in the future. I'm going to spend just a couple of minutes talking about the data piece of it, because that's where I've kind of spent the most time since I've been back, and it's an area where I think we have the most potential. As I mentioned, I think it's great that we finally have all 50 states, Puerto Rico, and the District of Columbia reporting in on the TMSIS data. It's a huge step forward that as of last month, we actually started to put out managed care encounter data in a de-identified way so that the public could have access to that. And I hope that as we continue to get better data quality and better data data consistency across all of those, that we can really start to see how it is that we can do a better job of understanding the patterns of beneficiary utilization, how we can do a better job of understanding what some of the drivers are as to why people go to certain settings for care, and how we can maybe start to drive that differently. One of the projects that I've been very involved in since last fall has been our efforts on the opioid epidemic. And data is really critical to helping us be able to understand that. We need to be able to understand where it is that people first present when they have overutilization issues. In many cases, it's the emergency department. One of the challenges with that is that because of privacy rules and some other things, we can't always be able to have that information about if somebody has a past history of substance abuse or other issues, mental health issues. We aren't able to really always know that in the emergency room. However, if we can show a pattern that people are presenting there with certain types of data points, we can maybe say, you know what, we might not know for sure that they have a history, but maybe because of these data points, we should assume they have a history. And then be able to take a very different approach to care coordination for those people. It can also help us, and one of the things I found really exciting in talking with a lot of the vendors who have come in to talk to us over the past few months, is how much you can predict patterns of where and how overutilization will occur. That's really important because right now we have 116 people a day dying from the opioid epidemic, and the more that we can figure out, particularly with our own beneficiaries, where it is that we think people are at risk for certain types of things. For instance, people age 65 and over, joint replacements are one of the biggest areas, or back issues are two of the biggest areas where people become addicted to opioids. They have chronic pain issues, they have that, but then what are the alternatives? Again, data can help us to understand what are the alternatives, how those alternatives are successful or not at treating that, and also help us to understand how we can predict for certain types of procedures in certain types of settings, whether or not those people might be at higher risk of opioid addiction, and maybe instead give them a different type of thing, whether it's some sort of ibuprofen and other acetaminophen combination, or whether it's some other sort of device, maybe that's a nerve blocker that would help them so that they wouldn't have that pain to begin with. So I think those are really important things where the data and what we do can really help to make decisions about how we can treat these types of epidemics. I also think the efforts that we're doing through putting more data out there and having it so that patients can have better control over their data is really important as well. As many of you know, the administrator feels very strongly about this because a year ago, last week actually, her husband had a massive cardiac event while at a hospital in Philadelphia. She was not with him, he was with their 2 teenage children, and they were calling her and needed information about his medical history. She did not have that information readily available because she was on a train or plane back to wherever she was going at that particular point in time. But because she's the CMS administrator, she was able to make a few calls and get it pretty darn quickly. Not everybody has that power, and I think what really struck to her on that was we need to get to a point where people have access to more of that, whether you're a caregiver for your spouse, your children, your parents, whoever, or even for yourself. It's helpful to have that information and to be able to have access to it, so when that event happens, which you hope it never does, but if it happens, you're able to get it as quickly as possible. In his case, the fact that she was able to get that information relatively quickly made the difference in that he's now one of the very small percentage of people who survived that kind of event, and thankfully was able to recover and go on. But what if she wouldn't have been able to get that information? And so that's one of the reasons that she's been really pushing the My Healthy Data initiative in terms of putting more data out there so that people can get it and put it in a form so that they can have it on their phone or wherever else so that they can use it. I know for myself, my mom's a Medicare beneficiary. She's widowed. I'm her primary point of contact. I keep a list of her drugs in my phone all the time because just in case something should happen, I want to be able to know exactly what I should be able to tell a doctor. But it would be great if I had access to a portal that would just tell me in real time all of the things that she's on, because sometimes she forgets to tell me things. And so I don't always know exactly, if she changes blood pressure medications or things like that. This would allow us to do that. And I think that's really exciting. I think also it's thinking about how we can think about new ways to approach how we can do our business better at CMS. I know we're looking at a lot of things like moving to the cloud for certain types of data, looking at new ways to make connections, looking at how we can be more agile and nimble thoughtful about thinking about our approaches to things. And I think that's really important because while our tech spend here is about $1 billion a year, which sounds like a lot of money, it's actually a drop in the bucket when you think that our total budget is $1.2 trillion. So unfortunately, though, we have to make sure that every single cent of that $1 billion is spent very well and very appropriately. And so it's something that we want to really continue to think about how it is that we can do more and how it is that we can do it in the most efficient way possible. So with that, I just wanted to say I'm really excited about today and all that you're going to learn, but I'm also excited about the possibilities for where we're going to be going at CMS. I hope to be back next year and being able to talk about all the cool new things that you guys are doing, but I definitely think that for right now, it's such a huge shift from where it was, from where I was here even 7, 8 years ago to where it is now, and I can only imagine how it's going to change in another 7 or so years. So I hope you have a great conference, and thank you so much for having me.
So thank you to Kim and George for that great kickoff this morning. A couple of things I captured and I thought were interesting and a really neat way to frame up the day for what's ahead of us. Integrity, innovation, and potential, the evolution of CMS. Just kind of captured the content of what both of our colleagues shared this morning. With that, next up is Steve Davidson, the CMS Group Director for the Center for Clinical Standards and Quality. He's here to join us to discuss their quality payment program. Welcome.
I'm going to raise this just a bit. Thank you, Angela. So you heard George talk a little bit about what Convergence was all about in his mind here at CMS. And when he asked us to talk about QPP at the conference, and I thought, that's great, because if there's a story to tell about Convergence, in our minds it's QPP, which is the quality payment program that my colleagues and I want to talk to you about this morning. It's a story about convergence of policy teams and product teams, development teams, engagement teams who do communication, education, and outreach. It's a story about the services and support that are associated with any program around help desks. It's a story of back office support for these programs as they execute. And it's a story about reaching outside of CMS and engaging clinicians and others. The thing that struck me most is that it's also a story about how CMS can converge across, in this case, 9 offices and components across the agency with over 12 contract teams working together with, again, clinicians and outside stakeholders to build a program that could be as successful as we think QPP has been. So today we want to share that story with you. And okay. What we're going to do is talk a little bit about how this alignment got started, the genesis of QPP as a program. We're going to talk about the integrated project team where this convergence took place. We're going to talk a little bit about the results that we've seen so far. And then we're going to share a little bit of a retrospective on some things that we learned along the way, things that we'd like to share with you, things that we got better at so that you can have the benefit of those lessons. So to kick things off, first we want to start with a video from Jean Moody Williams from our front office at CCSQ about how this program began.
Greetings, everyone. I am Jean Moody Williams, the Deputy Center Director for the Center for Clinical Standards and Quality. While I'm sorry that I can't be there with you in person, I'm very excited to be able to say a few words to you today by way of video. I'm actually out in the field listening to the clinicians and beneficiaries that are served by or participate in our programs. You'll hear why that's so important to this story I'm about to tell you in just a few minutes. First, let me paint a picture of the situation we were in over 18 months ago. Over the course of several years, Congress developed 3 different payment programs to incentivize physicians, nurses, physician assistants, and all other clinicians that bill Medicare Part B. Since these programs were enacted at different times, they all had different rules, timeframes for reporting, and incentive structures. Clinicians came to the point of finding these programs to be intrusive, hard to understand, and taking time away from patient care. Congress heard the appeals of many to do something to address the problem with these programs, as well as a problem with the sustainable growth rate law that had the potential to drastically reduce payments to clinicians. They enacted the Medicare Access and CHIP Reauthorization Act, better known as MACRA. MACRA combined all of these programs into one that was intended to simplify and incentivize high quality and efficient care. As a result of this change in the law, we found ourselves at a very important crossroad of how we would design the program. We could continue in the manner that we usually would and run the risk of combining 3 programs that clinicians already disliked into one big program that they could dislike even more, or approach this new legislation in a completely different manner. Many thought that we would continue business as usual, as reflected in some of the tweets and comments that began to emerge on social media at the time. There were tweets about, you see disruption, you see taking time away from patient care, and you see the word disaster. It became obvious that we could not continue down a traditional path for policymaking, system development, and education and outreach. We had to do something different. We had to learn from the various models of success in the industry, including reorganizing our team into more of a corporate model with an integrated project team approach. All of a sudden, I became the chief strategist of the quality payment program, as well as the chief marketing officer. None of these titles were necessarily common from the CMS government perspective, but the roles encompass everything I'm passionate about, and our senior leadership made sure to match responsibility with those that had the will to do the work. We developed an integrated project team, or IPT. Dr. Kate Goodrich was named the CEO, and we established a government structure encompassing leadership from all across the agency, as noted on the top vertical bars. We then identified all of the important work streams necessary for the IPT to cover all the bases without letting things fall through the crack. You can see that we have a policy, engagement, product, and service and support work streams. In the beginning, we had daily stand-up meetings, leadership meetings, workstream meetings, you name it, we had it. But for the most part, these were all quick touch bases, sometimes 15 minutes or less, just to make sure we kept the mission and vision in front of us. We acknowledged any barriers, and we removed any blockers. Normally, when implementing a new piece of legislation, we start by writing our policies and then sending them out for comment so that we could get reaction before we finalize. We didn't do that this time. We used human-centered design from the very beginning, even to determine our vision and mission statement. We initially started out by describing a desired state, which was CMS focus. We showed it to the clinicians and patients, and they gave feedback that completely changed the vision to what you see on this slide. After organizing ourselves, we knew that the next most important thing we could do was to have an agreed-upon strategy that would guide the actions of everyone on the team. We established the following objectives along with metrics. Having the strategic objectives was invaluable. Whenever we came to an impasse in the project, we would refer back to the objectives to see if this particular request, business requirement, outreach materials would satisfy the strategic objective. If not, it was off the table. I mentioned engagement and outreach, and it was essential that we receive constant feedback on everything we did, whether it was writing a policy, employing agile product development, or providing technical assistance. You see in this slide that the first thing you'll see is me taking a selfie with a room full of patients and families. We went to where they lived, where they worked, where they played. We talked with clinicians so that we could have all the input. As noted on the following, we tapped into every single channel that we could think of to get constant feedback on the program. Well, that's how the story began. I'm happy to turn it over to my colleagues that are there with you in person to tell you a little bit about how it ends. You will hear from the remaining work streams and their views and experiences. Thank you for letting me share a little of the journey with you, and I hope you enjoy the rest of the conference.
So wow, with vision and leadership and goals like that, how could we fail? Trust me, it's possible. And just to show you how hard this was going to be, I would like to introduce Rina Dusasia, who's going to talk about the engagement and the policies behind QPP that really will give the context for the complexity and the magnitude of the task at hand. So, Rina?
Well, thank you, Steve. Good morning, everyone. It's a pleasure to be here. My name is Rina Dusasia. I'm an emergency physician and the acting group director for the Quality Measurement and Value-Based Incentives Group. And I'm glad we had the opportunity to hear from Jean today to talk about the importance of human-centered design and engagement when we're looking at designing the quality payment program. And I'm here to continue that story for you. What I'm here today what I want to do is share the importance of engagement when we were implementing policy for the quality payment program. So the slide that I have here actually demonstrates the quality payment program's 2 participation tracks. The goal with the macro legislation was to move clinicians from paying for volume of care for beneficiaries to one that would reward for value. The 2 participation tracks in the quality payment program are the merit-based incentive payment system and the advanced alternative payment models. And I'm going to go into details for both of these during the time I have with you today. And before I start, Jean actually went into the importance of strategic objectives as we were considering the quality payment program. And I wanted to highlight 3 of these because I think these are highly relevant as we were thinking about policy development. One was the importance of improving beneficiary outcomes. And this was key, and you'll see with our policies in terms of it being patient-centered. The second was to promote program participation through customized communication, through education, outreach, and approach, and support. And then a key piece was also to reduce the burden on clinicians when they participate in the program. So when we were developing the policy, we knew that MACA represents a fresh start for clinicians participating in value-based payment programs. So we implemented a comprehensive engagement plan. It focused on human-centered design to help develop our policy recommendations, a communication strategy, as well as an outreach and education plan. And we also developed the quality payment program portal to engage with clinicians as they were submitting their data. Some of the activities we undertook for engagement included this next slide that I have here. These included national stakeholder calls we held frequently, at least once a month, with more than 30 organizations. We also had clinical champions, and what I mean by that is that we had a cohort of 12 actively practicing clinicians who served as our external program ambassadors and provided feedback on our program materials. Third, we had clinician voices. So we had a group representing hundreds of clinicians that would reach out to CMS to offer us comments and voice concerns about the quality payment program. We also had technical assistant contractors and a QPP service center, and my colleagues here on the panel will talk more about that after I finish. So the first participation track that I mentioned was the merit-based incentives payment system. And what I wanted to highlight for you was that if a clinician was eligible to participate in this program, there were 4 categories. And again, as I mentioned, we were trying to move clinicians away from just paying for their services to one that would reward value. And you see these 4 performance categories. One is quality. So clinicians were expected to submit data on the quality of care that they were delivering to our beneficiaries. The second, cost. Again, when you're looking at value, you have to look at both, the quality as well as the cost of care that's being provided. Third, improvement activities. And fourth, promoting interoperability. Promoting interoperability is a key objective in terms of thinking about how do we exchange information across settings, and we want to incentivize this in this participation track of the program. The other thing that I want to highlight here is that what we really wanted to do was to get clinicians to participate in the program. So this next slide actually illustrates for year one what we did. As I mentioned, that we really focused on engagement of clinicians, and we wanted to really encourage participation into the program. So what we designed from the policy piece was to have something that we deemed Pick Your Pace, which was for participation in the transition year, which was the year of 2017. And I think this is key because what it allowed was for clinicians to get familiar with the program. And this is what we heard from the stakeholders as we were launching the quality payment program. And in this transition year, clinicians and practices had the opportunity to submit data through three approaches. One was submitting just a minimal amount of data, which we called a test path or track. The other was partial year, which they would submit data for 90 days. And the third was the full year. We would submit data for the entirety of the year. And, sometimes we're aligned accordingly to if you submitted more data or not. But the key was if you submitted any data, then you would not receive a negative adjustment for the first year. The second year actually continued with this theme, which was about trying to introduce additional flexibilities for clinicians. We heard from our multiple outreach efforts the importance of including virtual group participation. We also recognized the complexity of patients, and we included that in our policy. And we wanted to reduce the burden for clinicians. We also heard that some clinicians were having difficulty based on their practice patterns and the beneficiaries they were taking care of to have the infrastructure to report on this data. So we changed the low volume threshold to include clinicians who are billing more than $90,000 in billings and providing care for more than 200 Medicare Part B patients. Other modifications, in our first year, we actually had a 0% weight for our CAS category because we recognized for clinicians it was a relatively new concept. In year two, we moved it to 10%. We also introduced bonuses for clinicians to treat patients that are complex or are part of a small practice. And there were clinicians that were part of facility-based care. So you can think of your hospitalist or your pathologist who might be based as a part of a hospital. And we wanted to make sure that there was opportunity for them to submit data using facility-based measurement as well. And that was finalized for reporting starting in year three. And the other thing that we wanted to focus on was if we're going to drive toward value, we also have to make sure the measures that we have in our program are actually measuring improvement. So we also finalized in year two policies an improvement in looking at our measures and those that we deemed topped out. And what I mean by topped out are measures that don't have any variation of care, that are not really leading to what we find worth your bang for the buck in submitting data in terms of trying to incentivize high-value care for our beneficiaries. In year three, we continue to support these goals of program simplification and burden reduction. And we drawed on those flexibilities offered in the quality payment program and also was able to capitalize on the recent enactment of the Bipartisan Budget Act of 2018. So we're continuing to address further clinicians' access to all health information on their patients via interoperability. We're also continuing to support clinicians that might need additional support. So those are clinicians and practices in small, independent, and rural areas. And our policies actually are proposed right now in the physician fee schedule, which we recently published, and we're seeking comment through September 10th, and our aim is to actually publish the rule by November 1st of 2018. So I'm going to shift gears. If you might remember at the beginning, I talked about the two participation tracks in the quality payment program. One was the merit incentive payment system, and the second is the advanced alternative payment models. So I want to give you a little bit of background on what that means. So alternative payment models are new approaches to paying for medical care through Medicare that incentivize quality and value. And I listed on this slide examples of alternative payment models within CMS. Some of them are housed within our Innovation Center, also through our Medicare Shared Savings Program, and through other demonstrations required by federal law. And a subset of these alternative payment models are what we deem and what we call advanced alternative payment models. And I think the key here is like these models are to be applied to, for example, a particular condition, or for looking at a care episode, or for populations. And it offers significant opportunities for those clinicians who might necessarily might have some additional resources where they would want to move toward participating in a more holistic model and looking at quality of care for the beneficiaries that are in their practice. So the advanced APM, as I mentioned, is a subset, and it excludes eligible clinicians from participating for MIPS, but what we're trying to incentivize is for our practices and clinicians to have greater risk. And by choosing a more risk model, it will drive toward improved patient outcomes. And by doing the policy around this, what we did was build in extra incentives. So part of that is actually toward payment. Namely, we've written in the policy a 5% lump sum for those that are taking care of Part B professional services. So in conclusion, I hope that with the story that I shared with you today, the importance of engagement as we were designing the policies for the quality payment program as we launched into year 3. I'm going to hand it over now to Steve Davidson to talk about the service and support of the quality payment program. Thank you.
Thank you, Rena. So, I'm going to skip forward a little bit and talk about service and support. I'm going to start with that IPT house again. You saw this as part of Jean Moody Williams' presentation, but this one's a slight variation on that, where we've actually added a fifth pillar that adds the program operations functions that are part of this integrated project team that I pulled it out of the program management piece up there to show these back office activities that support a complex program like this. And I did that because this pillar is just as important as the 4 other pillars that we've talked about. It's critically important that budgeting and acquisition processes and all those things keep pace with the work that's being done on the program. In my slide, I also show the functions that are performed under those pillars in general, and how we thought that the key to being successful in this program was making sure that all of these pillars were operating together and communicating effectively to keep the program moving forward with as much speed, but with as little friction and rework and miscommunications and all the other things that can be associated with a complex program. Now, you'll recall that Jean spoke about the strategic goals that were set up originally, and the second one was about enhancing the clinician experience. And one of the objectives under that goal was making sure that every interaction that clinicians and other stakeholders, every time they touched CMS, they should have a positive experience. It made no sense for us to start building a system that was user-friendly and all that, but when somebody needed help or assistance or had a question, they had a miserable experience. It didn't help if you put out communications that was full of government speak rather than plain English. It didn't help if your service and support organization couldn't answer your questions. So we took a human-centered design approach to all of these pillars in order to make that clinician experience, regardless of whether it was getting communications from us, getting service from us, accessing our systems, and believe it or not, even applying human-centered design to the policy making associated with this program. So let me start to share with you what the challenge was. You saw the situational slide that Jean put up there around the programs that comprise MIPS and QPP today. This represents what the service and support organizations look like for the programs that QPP was replacing. So you saw 4 performance factors in Rena's presentation, and 3 of those were really rolling existing programs of PQRS, physician value modifier, and meaningful use into QPP, and adding a 4th performance factor around improvement activities. Now, these 3 programs were already large, complex programs, and the thought of rolling them into a single program and supporting them, along with the multiple APMs that Rena highlighted, represented an immense challenge. To build a system and a service and support organization and a outreach and engagement activity and policy that addresses all of those was an immense challenge. And when looking at the previous state, if we went forward with trying to support these programs the way we had been, there was no less than 8 different help desks supporting the activities under these programs already. And those help desks were situated on 4 different platforms. So it was no wonder that, clinicians, if they called, say, My QualityNet help desk and had a simple reset, but decided that they wanted to ask a question about APM participation, didn't get a good experience. The best we could do was say, you'll have to call this other number. Have a nice day. So if you guys experienced that before, you know that that's not the experience that we were looking for. The other thing that's wrong with this model too, of course, is that there's no one consolidated repository of customer contact. And how do you think that feels from the user's perspective when they calls and the person he's talking to doesn't realize that he's called yesterday at a different help desk and the day before at a different help desk? This is not the experience we were looking for. So when we sat down and said, what are we looking for? What are our goals here and objectives? And again, looking back to the strategic goals that was set up early in the program that Jean spoke about, first and foremost, we had to improve this user experience. We had to make sure that this was a good experience when they called for service and support. But also, there were a lot of operational challenges here. Yes, we got MACRA funding, but that funding was not unlimited. It would not last forever. We didn't know how much it was going to cost to build systems or to do our engagement activities. So we had goals of reducing operating costs over the long run, and we also wanted to minimize the upfront capital investment. But operationally, we also had to have the flexibility to address this problem of multiple help desks and how we could integrate those help desks into a single support function. And also, the nature of these programs is that they have surges in volumes and calls to the service center based on either specific events that happen on the program, like releasing a final rule or a new release of the software. We had surges, and we had to be able to scale and flex our capacity to support. And of course, QPP has a wide variety of personas, so we had to tailor our materials and our engagements to meet the various needs of people at different levels, whether it be a individual practitioner on a rural basis whose wife is the office manager as well, to a consultant who works with sophisticated registries. We had to be able to work with all these different types of people. Again, quite a huge challenge. So what do we do? One thing we decided not to do was try and integrate all of the individual help desks that were supporting these functions. And they included technical support help desk, program assistance help desk, technical assistance help desk. And the reason we did that is because we didn't have a lot of time. And the logistical complexity made it nearly impossible to think about trying to consolidate help desks. In addition, these help desks were properly placed within the component that they serve, meaning program assistance ought to come from the program team. Technical assistance ought to come from the IT team. We're better off being able to manage those things. But again, how do you go about integrating those services such that it's a good experience? Well, we thought the answer lied in creating a virtual service center. And the cornerstone of the virtual service center was getting these help desks onto a single platform where we had a single repository for contact history, where we could share tickets among the help desks, where we could establish consistent SLAs across all of the different help desks, and they worked together as one single team. Now, we're not completely there yet. Originally, we were able to combine the QualityNet help desk, and we were able to combine the MIPS program assistance help desk and the APM program assistance help desk. But we created the foundation. The product that we used was a cloud-based software as a service tool from ServiceNow. And we were able to create the foundation so that when these other areas that support clinicians are ready, and it makes sense from a business standpoint, we could invite them to join this virtual service center and invite them to engage with us to make sure that clinicians can get to the right people in the easiest and fastest way possible. In addition to creating a cloud-based platform that people would use, the telephony system is also cloud-based and able to give you ACD capabilities in the cloud without investing in expensive switching equipment and ACD systems on premises. And what that really enabled us to do was to be able to have a service desk that was boundaryless. There was really no reason why anyone had to be in a call center or at a specific location. All you needed was a PC and a cheap IP phone, and you're in business. So what does this service look like under this model? I hope you can see some of the comments in the back. I'll read them when we're done after I walk through this. So right now today, everybody calls one number. That was agreed upon as being an important first step. No confusion about who you call for what. You start in one place, and that's with the basic QPP support team that's operated through QualityNet. And our goal there from the beginning was to see if we could make service and support an experience that drove customer happiness. Now, not all clinicians and practices, are happy about participating in quality reporting, but it doesn't mean that they can't have a really happy experience when they call and their expectations are exceeded. So that's what we were striving for. So after calling the basic QPP support desk, we can answer about 83% of their questions on the first call, whether it be a simple password reset or even a policy question. But there are times when we get a complex policy question such as, I work in a specialty practice XYZ, and I want to talk to you about what's the right measure set for me to use for my reporting. That's not something we can typically answer at the basic QPP support level. So we asked the caller if they would be willing to have us escalate the call to a specialist. And they say yes. And we tell them that the specialist would be better able to answer their question than we're prepared to do. And so what we do next is we put them on hold, and we call the MIPS Program Assistance Help Desk or the APM Program Assistance Help Desk, depending on the question. And we get an agent on the line. At the same time, we transfer the ServiceNow ticket to them, so they have the profile information of the caller as well as the nature of their question already in front of them. And we bring the caller back online. We introduce them to the Program Assistance Help Desk agent, and the Help Desk agent there addresses the caller by first name and says, I understand you have a question about measure sets that would be appropriate for your specialty practice of XYZ. That's a good experience because the caller doesn't know that he may have been transferred to a different contractor, run by a different component, in a different location. All they know is that they got escalated to someone who can answer their question right away. That was the experience we were looking for. Some of the quotes we get as a result of these types of experiences, I'll read. I don't know if you can see those in the back. Raise your hand if you can see them. Okay, that's pretty good. I'll just read one then, in case, where Peter Morningsnow, he got a compliment from one of our callers that said, Peter was definitely one of the most courteous representatives I've spoken to. He even offered to explain things in ways that a layperson could understand. In addition, he offered to stay on the phone until my inquiry was fully resolved, which I absolutely appreciated. This was the feedback we were striving for. So another element of our service and support has to do with the technical assistance programs that were already in existence within CCSQ. These programs were set up to provide technical assistance to clinicians and practitioners participating in our programs to help them report properly, help them improve their performance and clinical practices. And while they're not integrated fully technically within the Service Center cloud solution, from a process standpoint, we absolutely integrated them. At the end of every day, we would make a list of all the people who called the Service Center, and we'd send it over to the technical assistance contractors that was appropriate for that caller. And within 24 hours, the caller would get a call from the technical assistance folks saying, hey, I understand you called our help desk yesterday to ask a question about measure sets. Is there any other questions that you have that we can help you with and follow up on? And by the way, we offer a wide variety of technical assistance activities that maybe you would be interested in as well. And at first, many of the callers are kind of in disbelief that the federal government is calling them back, reaching out to them. And then the next question is there a fee for this? And the answer is no. We are looking at this from the clinician's perspective and trying to provide that wonderful experience and help them successfully participate because, as Rena mentioned, that was our goal, was to get people to participate. All right, so what kind of results have we seen? Well, first of all, right now we can say that we operate our service center at a world-class level in terms of industry standards. The slide says 15 seconds, but things have slowed down a little bit since we introduced feedback back in early July. Last week we were averaging 10 seconds on the answers. 2 to 3 rings and they got a human being on the line. I think that's terrific. Our satisfaction rates have been over 90% with respect to the service center, over 99% with technical assistance. People are just amazed with the outreach that's taking place there. And as I mentioned before, high first call resolution. The other thing is, I'm not going to read these goals again because we talked about them already. We have integrated the service and the system functionality, something we haven't done in the past. But now as part of QPP, I guess clinicians and users, if they want to initiate something like a hardship application or a appeal, targeted review as we call it, they click a button within QPP, and that button takes them actually over to ServiceNow, to the public portal on ServiceNow, where they fill out an application, they hit submit, and it puts a case into ServiceNow. And by the way, that the ServiceNow screen has been reskinned to look exactly like QPP, so the user never knows they're leaving QPP. And after they hit submit, they go back to QPP. Then if they want to check on the status of their call, of their ticket, or their case, I should say, they would call the service center, and inherently right in the system, the agent can tell them the status. That's the kind of functionality we were looking for. With the cloud-based solution, software as a service, we think we've got operating costs under control, minimal investment, and the flexibility we need to scale. So that's the story of the service part of the service pillar within that IPT. Next, I'd like to introduce Stan Ostrow, who's going to start to talk about the product and the building of that QPP system.
Good morning. Thanks for coming out and hearing about our QPP journey. We knew from the beginning of this project that we wanted to get away from our old waterfall processes and move into agile development. Making such a radical change, we knew we had a few opportunities that we had to address. So we needed the right people in place, right, to lead this change from CMS. We knew our processes, everybody here knows our processes are no way agile, and we wanted to move to cloud technology. So everything that you guys would think why we can't do that, we thought the same things. And we had to change the culture. Couldn't keep thinking the way we thought, we had to change. So we had to empower our people to feel like they could make decisions. There was a lack of transparency, we had to fix that. And we needed senior management buy-in. So changing our processes, we knew we wanted to go to Scrum. We knew we had to change the way we did DevOps. We knew contracting was an issue. We couldn't take 6-8 months to award contracts any longer. And we needed to put all our contractors and all our CMS people together in one facility. Technologies had to change. We needed tools for automation. Like I said, we wanted to move to the cloud, and we wanted to go to APIs. So how did we do this? Number one was senior management buy-in. We had to go get management approval to do everything. We needed their buy-in. And with their help, with Steve Davidson, our lead in ISG, our CCSQ front office, OIT senior management, CM, CMMI, OIDA, and the Office of Administrator, put together an all-star integrated project team And a lot of you guys are here today, and this is really about you guys, and you're the star of this story, really. We were also lucky enough to bring in the U.S. Digital Services. They really set direction for going to AWS Cloud. They brought in new collaboration tools. Brought in new collaboration tools with Confluence and Jira and HipChat, API first mentality, and go into open source code. Contracting, we have a new contract vehicle, a Dell BPA. We have 6 small vendors on there, which I call they're professional agile developers. They've really pulled CMS in to the agile world. We started small. We started with 5 sprint teams. Each team was responsible for a small piece of the system. We brought in agile coaches. They coached the CMS people on agile. They helped with the agile processes with our contractors, and that was really, really beneficial to everybody. Made sure we were all on the same page. January 1st, 2018, we opened up our authenticated portal for submissions. By that time, we had over 20 sprint teams. We knew we had to do a better job with the interaction between our teams and integration. We knew we had to do better long-term planning. So working with all our coaches, working with our contractors, we decided to move into Safe Agile. We kicked off our first planning session the end of June, where we brought in all of our developers, our architects, our CMS stakeholders with policy and E&O and communication, and 180 people together for 3 days. We went over our priorities, our features, and detailed planned out how the next 12 weeks were going to go and what work was going into what sprint. Parallel to that, our little project management team also was prioritizing the next 2 program increments. So now we have a roadmap going out 24 weeks, which we never had before. So it's really taken us a long way in our planning. And I think everything's really worked out. Our next session is the end of August, and I think that'll take us another level up. So we haven't done everything perfect on this project, far from it, and we know we have some issues. But we have put a dent in changing the culture, changing our process, and changing our technology. So we've hit all of our legislative mandates on time, and we've been under budget. So far, we're doing okay. Hopefully, we continue with that. I'm going to turn it over to my partner in crime, Mindy Riley, and she's going to talk about our human-centered design.
Good morning, everyone. I'm Mindy Riley. I am one of 4 product owners for the Quality Payment Program. I am also in a hybrid IT and policy role, so it makes me a little unique as part of the IPT. It brings policy and product closer together and helps us better understand the needs of each group. So this morning I'm going to talk about human-centered design. Give me a second. I can't read with my glasses anymore. So another aspect of the change for CMS has been introducing human-centered design. This approach, it's been instrumental in helping us meet several of the strategic objectives that Jean mentioned earlier, such as reducing burden, delivering IT systems to meet the needs of our users, and ensuring operational excellence. User research concepts and staff are embedded across the entire QPP continuum, not just the development teams. We've worked closely with many different stakeholders in our endeavor to understand their needs and their challenges. We've collaborated with clinicians, administrators, EHR vendors, registries and QCDRs, professional associations, consumer advocates, and other important stakeholders. We also have worked closely with our voluntary clinician champions and our clinician voices. The input and the feedback have helped us identify opportunities for improvement and ways to continue to reduce burden in the Quality Payment Program. Our most recent implementation of this approach can be witnessed in the Year 3 proposed rule. The policy, product, and engagement teams work closely to create a set of wireframes that are now part of the rule. These wireframes are available to assist rule reviewers to better understand our eligibility, submission type, and data collection type proposals. The results of this approach have been overwhelmingly positive. We've even been told that QPP has saved at least one marriage. But our work is not done. We continue to expand this approach with each new feature, each new policy. We also continue to improve our existing functionality through the feedback we've received. So what have the results been so far for the Quality Payment Program? QPP has been able to meet or exceed our submission goals for the first performance year. We're pleased to announce that 91% of all clinicians eligible for MIPS participated in the first year of the Quality Payment Program, exceeding our 90% participation goal. We've also had remarkably high participation from accountable care organizations and clinicians in rural practices, whose submissions rate were 98% and 94% respectively. These numbers speak to the combined efforts by clinicians, professional associations, stakeholders, and many others who work tirelessly to ensure high-quality care and improved outcomes for patients. This success cannot be celebrated without recognizing the technical assistant networks that provided free support to the clinicians who were included in the Quality Payment Program. The Small, Underserved, and Rural Support Initiative, Quality Innovation Networks, and Transforming Clinical Practice Initiative all work tirelessly to help the clinicians familiarize themselves with the program so they could successfully participate. Our goal was to ensure the networks responded quickly so the clinicians could spend less time figuring out the program and more time with their patients. You can see from the results on the slide that they had incredibly high levels of satisfaction while they were able to provide the support. We've received comments from numerous channels about the evolving policies in the QPP portal. Some are not always positive, most are. These comments are signaling, though, that we're on the right path and that the work we are doing and the approach to the work is changing how CMS is working with our clinicians and beneficiaries for the better. And please join me in welcoming Steve back for our retrospective.
Thanks, Mindy. So we wouldn't be agile if we didn't do retrospectives, so that's how I thought we'd finish up today. I'm probably going to go through this fast, try and recover a little bit of time, but I'm going to hit some of the major ones. The first one is really, really key. A lot of times you'll see a slide that says a key to success is leadership or management support. Well, support is not enough is what we found. Engagement is what is needed, and as mentioned, we had that all the way up to OA, through our front office, across the agency. We had engagement by everyone who was part of this program. Obviously, we've mentioned that having clear goals to provide the focus for the entire IPT is really critical. If you're going to change the way you work, the way it works here at CMS is you're going to have to change contracts. Don't postpone that, don't ignore it. It's an essential part of making sure that you're going to be successful is working these contracts so that your partners and the folks in this room, or a lot of those, can work with you to make change. We had help. We had help from U.S. Digital Services. We had help across the agency from OEDA and OIT and others. Get help to fill gaps in your skills. We couldn't have done it without the entire engagement of the agency. Having a lean culture and help in place already helped us, so we were accustomed to improvement and continuous improvement. Having coaches and providing training, Stan touched on that, critical. It's very easy to fall back in old habits when you are trying to change your culture. And I want to underscore the last bullet a little bit, because having that environment not only in our view is essential to getting that collaborative work done and making decisions in real time and figuring out problems in real time rather than doing handoffs and emails and waiting for decisions and things like that, we think is really critical to being able to keep things moving along quickly. And I wanted to show you the facility that we've been working out of. It's right outside the North Gate. Many of you know it. Some of you have been there. It is a cubeless space that really has allowed us to work collaboratively as a team. The facility has, if this works, what we call collaboration tables, 13 of them around the perimeter, where small groups of 4 or 5 people, sometimes just 2 or 3, work together on their part of the work. There's team rooms across the top there one big one that holds up to about 16, and the other 3, you know, chairs aren't right, but the other 3 hold typically between 8 and 12 people. This is where teams of a little larger can go off and work. We have a big open space in the center where a lot of the higher level stuff is done, where we keep things on the wall that help all the teams keep focused on what we're doing. And then, of course, the largest area is our conference room, where you have a dividable space that can hold up to 100 or so when the dividers are down, but also can be divided into smaller rooms that hold 20 people. So we've got space for just about any size group. And we've got micro team rooms and a couple of telephone rooms where 2 people can go off. But this creates an environment where if you don't know the answer or you're stuck on something, you can usually walk down the hall and find somebody who does and move on with your work. To see this work in action, I have a couple of photographs. The first one is around those collaboration tables. The second one, that looks like a sprint demo because we have all the walls open and everybody is looking at the sprint. The third one is the open space. And you can see, by the way, that most of the walls are writable walls. There's whiteboards everywhere. There's stickies everywhere because that's how this work gets done. And then last one is what the conference room looks like when the panel is closed. That looks like actually 2 of the rooms combined into one. But this kind of space is really essential to working in this fashion. So I know I rushed through that. I would extend an offer to any of you to contact us if you'd like us to talk about our experience in greater detail. It was a lot to cover today. My team is always happy to talk with you and help you with your journey, share with you our lessons learned, the mistakes we made, the things we did right. And with that, I'd like to thank you for allowing us to share our story with you today.
Thank you, Steve. I'd like to take just 1 second to welcome those of you that have joined us. I know there was a pretty decent security line, so for those of you that are joining us and haven't heard my voice yet, welcome. We're happy that you're here. I'd also like to add just a quick friendly reminder to silence your phones, and everybody's doing a really great job managing the sound. Just a quick reminder also that when having conversations with the exhibitors that are out in the hallway, the noise does carry through even though we've got those doors closed, so thank you for your attention to that. Without further ado, next up is Bobby Saxon. So Bobby, I'd like to welcome you up. There you are. Hi. Welcome. Bobby is the CMS Chief Technology Officer with the Center for Consumer Information and Insurance Oversight, and he's here today to discuss Marketplace. Welcome. Welcome. Hi. Good morning.
Thank you. Good morning, everyone.
As you
should say, it's not just Bobby Saxon, it is also Ron Graham, who is actually the lead on our cloud implementation that we're going to be talking about today. Ron, unfortunately, was a late addition, and we didn't not get him on the introductory slides here. He's not happy with me right now that we just have just his name up there. We want to really have a conversation with you over the next 45 minutes or so about what we are doing in order to get to the cloud. Our organization, CCIIO, the Center for Consumer Information and Insurance Oversight, otherwise healthcare.gov, is an organization that's been around for about a half a dozen or so years, and we have had our feet in the cloud for some time. But what we have not done is gone all in on the cloud until about 9 months ago. And we want to share with you the story of this journey to this particular point. So, slide, please. Oh, that's us?
That door?
on the screen. It comes across.
Okay,
Understood.
great.
Okay.
So, Ron and I are going to tag team this. We felt like, from my position as the CTO, from his position as the lead and really the day in and day out implementer of our cloud strategy, that we could really kind of share our story with you. And we're going to talk in three broad topics today. The first is what is happening, our actual move to the cloud, what's going on day in and day out, how are we getting this accomplished. The second is why are we moving to the cloud, what's important to us as an organization for us to be in the actual cloud. And the third is how are we actually getting this accomplished. Slide, Ron. So let's talk a little bit about what it is. In our organization, we currently exist in 3 different data centers in 3 different states across one large contract with multiple subs and 2 kind of bigs involved in our data centers, which is both good for us and bad for us. And we felt like in order for us to get in the right place where we wanted to be, we really needed to adopt an all-in approach to the cloud. And so we ended up last summer starting to make this movement for us to get to the cloud. Ron, you want to talk about some of the systems that are in the cloud today?
Some of the systems that are in the cloud today, we have currently the SLS, the simplified login system that's in the cloud. A lot of the systems that are, I'm sorry, can you not hear me?
Your mic might not be on.
I thought it was on. Can you hear me now?
There you go. Yeah.
Okay, maybe I just need to put it in a different spot here. Okay, so there are several systems that are currently in the cloud, primarily the systems that are managed out of the Office of Communications, the SLS, our MCR is in the cloud, the Medicare Consumer Record, and the DSRS is in the cloud, which are recent additions to the cloud. So we have a small footprint there, but the major systems that have yet to be migrated. I think that's kind of...
So our organization, when we stood up originally, we started bringing the organization to life back in 2010, 2011, 2012 timeframe. We probably should have gone all in on the cloud at that point, but there was concerns that we were not able to get past that said, let's go into the data centers. So we started building all of our stuff in the data centers. As is well documented, we had some challenges in October of 2013, which caused us to aggressively take some different approaches to how we stood up software. So we brought in one of our partners here in CMS, the Office of Communications, John Booth and his team, to help us bring to life and to correct some problems that we had. And John and his team were very cloud-focused and cloud-oriented. So they started bringing things to life for us in the cloud, and that's some of the applications that Ron mentioned. And since then, as we have built new capabilities, we have brought those capabilities to life either in our data centers or in the cloud, and more into the cloud approach. And so when we started looking at we needed to go to the cloud, we looked at, well, what do we have in the cloud already? What's our footprint? What experience do we have? And how can we leverage that experience? And then how can we also get the rest of our systems into the cloud? And so some of the things that are talked about here on the slide are what we've moved, what we're in the process of moving, and then across the top, the State of the Union is that, as I've already mentioned, our technology is kind of all over the place, some fully in the cloud, some not in the cloud. We have disaster recovery that is in place technically, but we don't feel very confident with because functionally it may not be as strong as we need it to be. And we felt these were things that we needed to address long term, and moving into the cloud would be the way that would help us to do that. Ron, can you hit the next slide?
Sure.
So the benefits of moving to the cloud, I don't think I really have to spend a lot of time on that, but I'm going to, because you know in general what's important about the cloud, but what was important to us about going to the cloud. And the first point up here is improved performance and stability. Our organization is built for 45 days a year from an IT point of view. Now, that's not exactly true because we have lots of business owners that work extremely hard year-round. Their business cycle is outside of open enrollment. So they have important periods in January and in the summer and in the spring that are just as important to their particular business mission as open enrollment is important to the overall mission of the organization. But in order for us to handle 1.8 million plan selections on December the 15th in 2017, we have to have a system in place 365 days of the year that can handle 1.8 million plan selections. And I believe the number is approximately 90,000 concurrent connections to our system on December the 15th for like 12 straight hours. And so our infrastructure that's in our data centers right now has to live for that, which is a challenge for us to maintain that kind of an infrastructure all the time. But it's really a challenge for us when we need capacity for 2.5 million people and we're kind of maxed out at 1.8 million. That's one of the reasons when I look up here and you say performance and stability, can our system perform the same on February the 4th as it does on November the 1st, the first day of open enrollment? And can it be stable? Are we going to bring the system down? And we have a history in our organization of running into challenges, most of the time around capacity, of our system kind of dropping to its knees because we couldn't handle the volume and we were unable to stay stable out there. Ron, you have anything to add to that? Ron's lived through most of this.
Yes, I have.
Yeah.
No, I think you've stated it quite eloquently. Having to maintain that capacity year-round is a challenge. Managing to that peak, which is only needed for that short duration of time, I mean, that is a major motivation for getting to the cloud, to provide that scalable performance.
The second bullet up here is reduced system complexity. When you have part of your system in one data center, DR into another data center, and another part of your system in that data center, DR into another data center, and then you have some stuff in the cloud, and then you have multiple vendors, and you haven't set, because of the way we got out of the gate and the way we had to overcome some of the challenges, we kind of lost some of the simplicity of how our system should work. And when we looked at the cloud, we said if we take our time and we get into the cloud, then what we can do is we can kind of right-size some of the stuff some of the mistakes we've made in the past by moving into the cloud, standardizing our architecture, standardizing our approach, setting some left and right limits on how we expect things to get done, as well as some minimum standards. And we'll talk about that a little bit more.
Yeah, and if I could add something on the DR piece, while given our current complexity, it makes it difficult for us to effectively execute tests of the DR strategy on a sustained basis because of the complexity. There are lots of moving pieces, as Bobby laid out. So our ability to exercise that and prove a functional DR capability is challenged by the current environment and the complexity associated with it. So we're hoping the cloud migration will address some of those concerns.
The last piece, which I kind of touched on a little bit earlier, the elasticity. We really need the ability to shrink and the ability to grow. And we need that because we're concerned about that period of time between November the 1st and December the 15th, but also because we don't know what the future looks like for this particular organization out there. You probably are keeping up with the news. This program is constantly facing different types of challenges out there. Those challenges may mean that we end up growing as an organization, or it may mean that we end up shrinking as an organization. Being in the cloud gives us more flexibility in elasticity to shrink or to grow depending on what the future looks like, in addition to solving our challenges for performance and stability.
Yep.
And then the long-term benefits, so much of what we just talked about here, but we want to go all in on continuous improvement and continuous development. We want to go all in on DevOps. We want to go all in on prod testing. One of the challenges we had previously in our organization is we had very small environments where we were doing most of our testing. We weren't able to test performance. We weren't able to test stability because we simply were testing on half a dozen machines as opposed to our full prod environment. We changed that last year, but in order to change that, we literally have to shut prod down overnight in the August, September, early October timeframe in order to do this prod testing. We want to get to an environment where anytime we want to do a full stability test in prod, we can take advantage of that. Now, we could do it in a data center, but has anyone got a couple $100 million that we could borrow to end up standing up that infrastructure for that capability? And Ron leads our testing also. You probably have something to add to that.
Yeah, absolutely. The ability to spin up test environments on demand to test out capabilities is something we're very limited in our ability to do today, that we think the cloud environment will provide tremendous advantages for us. So that's a key benefit we're looking toward.
You also see up here, we're talking about reduced costs. No one says go to the cloud because it's going to be cheaper, other than the cloud vendors say that. But when you really dig into people talking about the reality of being in the cloud as opposed to the data center, you may or may not save any money whatsoever. In our particular case, though, we do believe, and we have modeled out in our initial investment to get to the cloud, that we're going to see 20 to 30% savings in year one, which is a partial implementation year, and then we think we're going to see 30 to 40% annual savings after that. Again, because of that elasticity point there. We keep that supersonic jet engine going 365. We know we can scale down. Like today, there may be 10,000 people in the system today. There'll be 1 million people in the system on November the 1st. So we can scale down to that 10,000 load and reduce our cost right there. Also, and speaking frankly here, because we got a lot of folks in here talking, want to know how you may get involved in what we're doing. Because of the way we came to life, because of the fact that we stumbled coming out of the gate, we ended up in some places where our contracting may not have been as supportive for us as we needed it to be. We needed to solve a problem immediately, but that caused a long-term problem with us fiscally. And so we're going to be able to fix a lot of that in our getting to the cloud move.
Yeah, if I could add a couple more points, Bobby. I just thought about on the testing front. One of the, as most of you probably know, there are multiple types of testing that needs to occur across the various systems that we maintain. The ability to do performance testing in today's environment is somewhat constrained because we, obviously at the scale of our production systems, we don't have our capacity to test at production scale in a test environment is very limited. So getting to the cloud will, again, give us the advantage of spinning up full-scale test environments as we need them to be able to gain more confidence in the performance results in ways that we can't realize today. So that's a key advantage that we're looking for.
Slide, please.
Yep.
And while Ron's moving the slide, if you have some questions, that WUFU website that was given out to you via the emails that's on the doors, it was part of your registration, go put those questions in. We are reserving some time at the end to answer easy questions, softball questions. But send us those questions, and we're gonna go through some of this other stuff fairly quickly so that we actually have some time at the end to answer those questions.
I'll take the softball questions.
Yeah.
And,
Okay, sounds good. So the approach, how are we getting to the cloud? What you typically hear when someone is moving to the cloud is do a lift and shift or do full optimization and move into the cloud. We did not feel like that either one of those two approaches was going to fit what our needs were. And so we made a modified approach that we are following, which we call the LISO approach, which stands for Lift, Improve, Shift, and Optimize. And so phase one for us is the Lift, Improve, Shift piece. What we are in the process of doing is we're going to pick up systems where we can make modifications to either the systems, how they're setting on the platform, their use of data, and so on. We're going to make those changes as we move them over and sit them down. So we'll immediately then be able to get some benefit of being in the cloud other than just simply picking it up and simulating our data center approach out there. And then in phase two, we are going to do the optimization piece. Now, in some cases, we're doing some optimization as a part of our total move because we had a couple of systems that were really kind of in a bad spot. We felt like we had to make some pretty significant swings at these particular systems. We're doing that as a part of our move. And when they get into the cloud, they're going to be kind of at the optimized approach in the first place.
Yep. So I can't add anything more to that.
Okay, so I'll add one other thing to it. The LISO approach for us is going to get us where we need to be, we believe. And ultimately, when we get into the optimized phase, we're going to be probably several years in the optimized phase because there's a lot of things that we want to do to take full advantage of being in the cloud. But our vendors, remember we said that we have been doing some cloud work for some time. We just haven't been all in on the cloud. So we have been following an approach. And when we first started putting the word out last summer, hey, we're headed towards the cloud, then we put out guidance that said cloud first. So if you were going to build something starting last summer, do everything in your power to put it into the cloud. If you couldn't do that, then build it cloud ready, so that when we did get around to picking it up, it would be a much easier move for us, but it would also already be leaning towards the optimized phase. The next thing is that we said build it cloud agnostic. Now, in addition to that particular piece, I gave out the guidance that we were going to utilize CMS provided cloud services. Because what I didn't want is for anyone to come up and go, hey, I just found Billy Bob's cloud service out there, and I want to use Billy Bob's cloud service. And that would have created additional complications for us. So right now, CMS has cloud providers of Amazon Web Services and Microsoft Azure. And so we said, if you go into the cloud, we got to go into that. Now, most everything that we had already that was already in the cloud was in an AWS, but we do have an application that's over in Microsoft as well. So those three approaches right there have allowed us over the last year to already start leaning into the optimized phase, not just, oh, we're going to start optimization after we get there. So it was a process for us.
I will say I give Bobby a lot of credit for conceiving this LISO strategy, because it's been a key piece of CTO guidance to help frame our overall approach and to help decision making. I give him a lot of credit for that. Thank you, Bobby.
Well, I'll get you that money afterwards, Ron. No, what I will say about that specifically is we didn't realize how much of an advantage it would be to have that general guidance until we got a little further down the road. Yep. And some of our passionately aggressive contractors were coming to us with, hey, here's how we're getting to the cloud. And it was a complete redo of their system in order to get to the cloud. And unfortunately, because we're on a timeline of us going to the cloud, we started having to push back and then bring them back in alignment with the LISO approach. But when I came up with LISO, I did not know that would be a benefit of it. It just ended up proving to be a benefit.
Absolutely.
Next slide, please, Ron. So, Ron, this is really where your expertise is.
Yeah, so again, this is under the theme of how are we going to get there. Obviously, moving these many systems of the complexity and scale that we're talking about in the time frame that we're talking about, end of March 2019, begs for a strategy. You know, we had to have a plan to organize and plan out and conduct the migration. So what we came up with is a concept of grouping the systems, and given what we know about the profile of the systems, we're able to come up with three groupings. You see four there on the slide, because that first group are the core services that just about all of these systems need in order to be effective. So we immediately identified what those core services are and began the process of planning and designing the implementation of those core services, and that work is underway so that by the time we start the systems migrating, those services are there to be utilized. The first grouping of systems are group one, are fairly independent. They are not dependent on the open enrollment environment necessarily, although they provide key support for the program offices that manage the other systems. But they are fairly independent of one another, and they're not dependent on open enrollment pressures. So we were able to identify those systems as group one and so they are the first group that are planned to migrate to the cloud. The second group are the systems that, we had to be really careful about the business cycles leading up to and after open enrollment. And there were a set of systems that were what I characterize as somewhat loosely coupled to the core systems in group three. And largely, these are systems that exchange information with the core open enrollment systems through file exchanges. So they were it was fairly easy to identify what those interfaces are and design an approach that will allow us to effectively migrate those systems and maintain the interfaces through a file exchange approach. So a loosely coupled relationship to the group three systems. So we were able to identify those and begin the process of planning and coordinate those. Also, some of the group two systems had relationships with one another. So there were functional relationships that made sense. There was also an opportunity to migrate them based on their business cycle so that we did not unduly disrupt open enrollment and they could meet some of their post-open enrollment priorities. Then we have group 3. That's the lion's share of what's going to have to move. One more point about group 2. Group 2 has systems that have significant volumes of data that have to be moved. So we're in the process now of going through some very detailed technical discussions and coming up with strategies to migrate those volumes of data. Those of you who know these systems, Midas, Opera, big volumes of data. So that's by far one of the technical challenges that we're having to address. And we felt the sooner we got started on that challenge, the better, because we will have more of the same when we get to group 3. Okay. Group 3, again, the flagship systems, the hub, the E&E eligibility and enrollment systems and their ancillary systems, you see them there, HIOS, et cetera. That's where the bulk of the migration and the last phase of the migration will occur. That will happen after open enrollment. What I failed to mention for the group 2 is our goal is to get the group 2 systems migrated by the start of open enrollment, and some will actually be migrating in parallel. The group 3, we felt it was best to migrate those. It was impossible to migrate them before open enrollment, so they're targeted immediately after, starting in the January timeframe. As you can appreciate, there's a lot of complexity associated with migrating these systems, so it requires a lot of collaboration and coordination. We have teams of folks responsible for maintaining these systems that are working every day in the groups, sharing experiences, developing common approaches, reconciling schedules, identifying interdependencies, so that we can effectively plan out a migration that will assure the results that we're looking for. So that's kind of an overview of how we grouped it. Again, real challenges here.
So to add to that, one of the reasons that we grouped this is because we needed to work around open enrollment. Mm-hmm. Because in our world, when we went and asked and said, hey, can we cancel this year's open enrollment so we can move to the cloud, no one was having anything to do with that. And so we had to build a plan that recognized that if we were going to move something early that was critical to open enrollment, we had to get it over there early enough so we could get it stable and make sure it was fully functional with the rest of the systems. Or, like in the case of the Midas, for example, we're going to move it early because of the volume of data, but we're actually going to run simultaneous implementations, one in the cloud and one in our data centers, because the users of that data and that system, it was so critical to them that there's really no downtime, especially during and in the period of time right after open enrollment. So we didn't have a better methodology of, hey, we'll move that stand up, shut down kind of approach. So we're going to have two systems. Huge bulk of data that we're going to move over using Amazon Snowball in order to get that accomplished. And then we're going to synchronize that data between those two systems while we keep it running in the data centers for our existing users. And then we will slowly move everyone over to the system that's in the cloud. On one of the previous slides you saw across the bottom, do no harm to open enrollment 2019. That was the one consistent mandate from the very beginning. Absolutely. Is no, regardless of what we do, if there is any risk to open enrollment, we have to fully mitigate that risk or that system cannot move until after open enrollment. And because to us, uptime, for those of you who are tracking open enrollment and healthcare.gov, if there's a blip from November the 1st to December the 15th, 47 bloggers have written a story about it within minutes. It's easier I don't have to talk to my XOC when we have a problem. All I got to do is keep the blogs open because they know about it sometimes faster than we do. But we wanted to make sure that we were staying out of, decreasing peril for ourselves there in order to get that happen. While I mentioned the XOC here, this has been very complicated. This is a simple slide, but there's a ton of work that has gone into this piece of this. And quite frankly, because we are doing this ourselves, we had some learning lessons. in order to get to this point. And we've really gained a momentum. We've got stability in how our teams are functioning. But I want to recognize the folks that are on the cloud team. Anyone in here that's on our cloud team, stand up, please.
Don't be bashful.
All right. One,
There's
two,
a lot-
there we go. I'm
there's
seeing
a lot
more.
There's a lot
All right.
more.
Thank
They're
y'all
just
very much. I appreciate it. Thank y'all. Now, there were some shy people that did not stand up. Or the rest of them are actually working on making
There
this
you
happen
go.
right now.
We're working on this plan.
But we really appreciate it. Okay, Ron, next slide, please.
Okay, I think we're...
So this slide is just for reference. This is basically, when we started down this path last summer, which I'll talk about on the next slide, we didn't really have a process. We all kind of knew the general thing of going to the cloud, but we didn't have a detailed process. And as we have continued to mature, recognize things that we didn't know and that we need to create, we've created kind of a process in order for us to, how does a system go from where it sits today with no planning to fully functional in the cloud? This is the process as we have today, but this is a maturing process as we learn lessons. I point this out because for our brothers and sisters across the rest of CMS and HHS, I have told our team from day one, and Keith Taylor, not stand up, raise your hand, Keith. Keith has got the pen on this, that we are going to tell our story factually after we are finished. That we are going to share the good and the bad so that our parent organization, our sister organizations can benefit from our lessons learned on how we do this. And that's why these types of things not only are helping us get to the finish line, but we're wanting to make sure that our processes, and where we thought we knew something 6 months ago that we clearly understand today, that will be told in the story that we're sharing. Anything to add to that, Ron?
Yes, Bobby. I don't want anyone to get the impression that the planning and executing the cloud migration is a serial activity, as this slide might imply. There are lots of overlapping efforts that are occurring concurrently, but this is really intended to give you a general idea of the kind of things that we had to think about in order to carve out a path to migrate to the cloud. So, and there's a lot of complexity when you drill into each one of these bullets that we could talk about. So it's just a notional idea of the path that we've laid out to get us all get the exchange systems to the cloud.
And that's where we really have been blessed, because not only do we have great team members inside of the government, but we have a tremendous number of great partners, and partners who have learned over time to come to us and have frank conversations about today and the future in order to help us to be able to get to the right place. Also partners who have embraced communications and collaboration. So I have multiple companies on our project that you would think of as big contractors who would typically kind of work in silos. But I have company A over here developing a process, and we're like, man, that works great. Let's get this in the hands of all the other companies out there, because all these other systems are managed by other companies. And that has been truly beneficial to us, that our culture has been able to change internally how we do business, but also culture. While I'm on the topic of culture change, it's important for us to have our ducks in a row, because one of the things that we found out is our business owners actually cared what this cloud thing was. First, they cared about it because how are you going to mess up what I'm doing, Saxon, by your cloud move thing? And so we've had to have a lot of conversations. As a matter of fact, we recently rolled out a whole roadshow for our business stakeholders, and we do it now on a monthly basis. We go in, we sit down and say, hey, here's what we've done to this point, here's how it should be impacting you, what are your questions? And then we bring the whole cloud team in, and we have very frank conversations about issues. And it's been great, because sometimes our business owners bring something up that they're kind of aware of that we were unaware of when we were gathering up our requirements to move a system or the impact on them. They've also helped us to understand that sharing the story of this, both internally, externally, because I've briefed the states. We have state partners. I've briefed the state partners on what we've been doing with this. It helps everyone to kind of build a passion for going to the cloud.
Yep.
Go ahead.
If I could just add one more comment, Bobby, if I could mix a couple of metaphors here. Once I think we all got over the shock of the fact that we're going to the cloud, and it took a lot of, as far as the collaboration and all that is concerned, there are multiple teams, as we mentioned before, that have to be a part of this. And initially, I sort of liken this to lots of ships in the water. Once everyone got excited about the move to the cloud, everyone was working hard, rowing, trying to carve out their path to get there. And it took a lot of collaboration and coordination, and through principles like LISO and some of the other guidance that Bobby gave us, I think we're finally at the point where we're getting all the technical teams with their oars in the water, pulling in the right direction, sort of indicative of what this slide is all about. We've got a strategy, we know what our path is. I think we're finally at the point where everyone's got their oar in tune, pulling in the right direction. That's not to say we figured it all out. There's some real challenges out there, but I think we're all moving in concert in the right direction now. So,
One last thing on that. If we had been asked to give a cloud briefing and not talk about technology, we could have done that, because we would have talked a lot about planning and analysis and culture, because those were key things in our move to the cloud and so far our success. Last slide, Ron, please. We'll skip this one because we've been talking about some of this. Let's go to one more slide here, and because I want to make sure we got enough time for questions. The cloud migration timeline here, basically we're doing this pretty fast. In about an 18-month period, we're moving a big organization with multiple petabytes worth of data, dozens of systems, 3 different data centers, all into the cloud, and while maintaining full functionality the entire time of doing that. We started off with some pre-planning. We started picking up speed. We had a small group, then larger groups, and then everyone in order to get involved in this. And if we're successful, if we're not successful, Ron and I will not be speaking here next year. If we are successful, we will be done with this by the end of March 2019. And at that point, we'll go to the question slide, and I think you've got the other question. They're going to flip the slides on us, so if you had not sent in a question to WUFU, please do that. And do we have some questions? Yes, okay.
We do. It looks like we have 3 questions that have come in.
Okay.
And I believe they're going to flash on the screen, but while we're waiting on that to happen, the first question is...
Softballs.
Here we go. All right, let's see. What are your plans for, I believe it's Midas?
Yes. Is Josie out here somewhere?
Yeah, right.
Or Allison? Okay. What are our plans for Midas? We are moving Midas to the cloud. Midas is our data warehouse in our organization. It is big. It has a lot of our data in it. It is cumbersome, and there are users that are connected to it outside of our organization utilizing technologies that may not be as cloud ready. So that's one of the primary drivers for us staying where we are with Midas and standing up a simultaneous instance of it so that we can be in both places while we work through some of those challenges over there. We will have Midas in the cloud in the next few months. But Midas, for anyone who is using Midas today, there will be no changes to Midas through the end of the year for the most part.
Exactly. So our current timeline is to have the cloud version of Midas stood up in the early October timeframe with the objective, our goal is to be able to run Midas, the cloud version of Midas in parallel with the on-premise version so that our business owners have plenty of opportunity to test out the cloud version while not impacting their ability to use the existing system. So once they're confident that the cloud version of Midas is serving their needs, then we'll plan the cutover.
And this particular approach ties directly back to the do no harm to open enrollment statement. It's critical to our business owners that we not interrupt their business processes during critical times. And so that's what we're focused on. Next question.
Next question. What is your data management plan after several years of being in operations, And are you moving towards API regarding sharing and integration?
We have a plan, and yes.
That is a two-part, two separate questions.
Well, yeah, it's two separate questions. First of all, we as an organization are almost all in on APIs. Most of the things that we are delivering this year that will have a direct impact on what's going on in open enrollment have been built on a foundation of APIs. We already had APIs in place, and if you bring something to the table to build today, you have to have an API-first approach. Otherwise, you're going to have a rough time getting it off the ground inside of our organization, because that's how firmly we believe about APIs. Not only how it'll make our organization stronger, but it'll allow us to share our information and bring people into our environment much more.
Yep.
Go ahead.
Yeah, if I could offer a perspective on the data management piece, I read into that question, an interest in what are we doing with all the data that we've collected for this program after being in operation for several years. Obviously, we want to make sure that data is migrated to the cloud, first and foremost. But during the optimization phase, one of the things we've come to realize is that what we need is a program-wide sort of data archiving strategy that we can use the capabilities of the cloud to help us implement. So we'll be very much focused on working with our stakeholders to come up with an approach to archiving some of the historical data that allows us to take advantages of cloud capabilities.
And I'll add one more thing to that before we get to the other question. We as an organization have a lot of data.
Yep.
And we have it in some cases in a lot of silos. And in some cases, those silos look very similar to each other, but not exactly. So if you're 99% the same, you're really totally different because you don't know what's different out there. We have recognized that. Although we have been able to continue to fly this airplane with the data that we have today and the processes that we have in place today, we recognize that if we are going to be able to consume data better, have higher quality data. So a lot of stuff that Kim Brandt was talking about earlier up there are the things that we, at the tactical level, we are addressing. We have recently stood up a data strategy team. Our new IT strategy and roadmap is including data strategy in there. We've just kind of been making data happen previously, but we're going to put formalized strategy to it. Ultimately, it is our desire to have good, clean data that is accessible to whomever the stakeholder is that has authorized access to that data to be able to utilize it, and that the tools that make sense for them are readily available for them to be able to take advantage of that. I typically talk a lot about 80, 15, 5 percentages-wise, different for every organization, but for example purposes, 80% of our users, both internally and externally, give them access to data in an Excel spreadsheet, kind of something with a couple of charts and graphs. They got all the data analytics they want in the world. Make that self-service and they are totally happy, and you are the best data provider in the whole wide world. Then 15% of our folks are folks that have more skills with the tools, have better understanding of the data, and they pretty well are saying, hey, get out of my way, let me get in there and get access to this data. And then there's a 5% that basically needs a data scientist. And so we're driving towards that as our long-term strategy for data management.
And Bobby and Ron, I'm sorry to interrupt, but we have time for about 2 more questions.
Two more
so we'll
questions.
take the next 2 on the list.
Yes.
Take the easy one.
All right. I'll let you choose.
Okay.
Okay, so will we essentially pay double for Midas for a while due to running 2 versions? I don't think that I've been unclear about that. We are going to stand up a second version of Midas for about 3 or 4 month period to allow us to get that version up, get it fully stable, and we're going to keep the other system running so that we can serve the needs of our stakeholders during and after open enrollment.
Do you have any mainframe?
So we're going to skip the mainframe one for now. We don't really have any mainframe issues.
Nope.
AWS and Azure, we are only using AWS or Azure. That's because CMS, when we decided to make this move, we needed to make this move by the spring of 2019 because of contractual obligations for our data centers. So we had to make the move fairly quickly. We went to CMS. What does CMS already have contracted and providing? And it was 2 providers at that particular point. You may recall that I gave out guidance earlier that said we would be cloud agnostic if at all possible. The reason for that is our first goal is to get into the cloud, our second goal is to optimize, and our third goal is to be in the right cloud that is right size for us, that provides us maximum capabilities at the least cost. And being cloud agnostic now, where possible, will ultimately allow us to then go to other cloud providers as those become part of our atmosphere.
So there's one question here about the
And this will be our
cybersecurity.
last.
Yeah, this will be, you want to touch on the cybersecurity one? I could just say there that we're working in lockstep with our cybersecurity office in planning our cloud migration strategy. So, that's a close partnership. So we think the collaboration there is good, so we're going to make sure that we're ensuring our cybersecurity office is strongly engaged and that we're protecting our assets as we migrate to the cloud. So
yeah, if you want to be in the paper in federal IT, mess up cybersecurity.
Yep.
So we all recognize that,
Yep.
and we have had our cybersecurity teams actively involved since day one in order to help us do the right thing. Sometimes that's a pain in the butt for us. But at the end of the day, we trust those guys. They're doing a fantastic job, and they're not only giving us great guidance, but sometimes they're working with us to come up with an alternate solution that provides the security that we care about, that they care about, and allows us to keep moving in our move.
and they're already protecting us. in
Yes,
the cloud.
yes,
We've
yes.
already got a footprint.
We've got a
there,
lot of
so we're
stuff in
just
the cloud.
expanding on that.
Thank y'all very much. Greatly appreciate it. Ron and I both will be around for a while if you have any questions. Thank you.
Nice job. Thank you. All right, I can see people are on the move. One quick friendly reminder, there is Wi-Fi access in the building, which is also probably going to be helpful for you to join WUFU to ask questions. So the questions that you saw populating up on the screen, those are coming through that URL that I mentioned, that again is posted around the room. And again, remember it starts with HTTPS. Don't forget that S. As far as the wireless, I'm getting to that. Thank you for the question. The wireless, the SSID is Freedom, all in capital letters. That should pop up on your phone. I just tried it on my own. So again, Freedom in all capital letters. The username, if you need, is CMS guest, all lowercase. I'm going to repeat this all back if you want to grab a pen. And then the password for that, capital CMS. All of those are in caps. So again, the password is capital CMS, capital guest, capital wireless. So guest has a capital G, then lowercase UEST, capital for wireless, capital W, lowercase IRELESS, and then a 2018 at the end. Okay, hopefully if you need a pen, you've grabbed it by this point. We'll repeat that back one more time. The SSID is Freedom, so that's what you're looking for. The password, capital C, capital M, capital S, capital G, lowercase UEST, capital W, and then wireless, all in lowercase, 2018. Okay? All right. Good morning again. It is now my pleasure to introduce Jack Fletcher, CMS Senior Technical Advisor with the Center for Medicaid and CHIP Services, to talk to you about Databricks. Welcome.
Hi, welcome. My name is Jack Fletcher, and I am the Senior Architect for MacBiz. With me today are Jenny Kim, Solutions Architect of Nuna Health, and John Schmidt, Senior Data Scientist with Mathematica Policy Research. So today's theme for the Convergence was digital transformation to put the patient first. So we love that theme. We at CMCS think that we are doing a lot to digitally transform our Medicaid and CHIP data into data products that provide useful and meaningful information about Medicaid and CHIP patients. We collect immense amounts of data from the states and pharmaceuticals through our MacBiz operational systems. Currently, we store about 3 petabytes of state-reported Medicaid and CHIP data at AWS. We are currently putting that data into our analytic reporting environment for MacBiz and implementing new technologies such as Databricks to build data products and patient-centered solutions. Today, You will see a demonstration by John Schmidt of NPR using Databricks notebooks to show how we are digitally transforming data into patient-centered solutions. The two prototypes developed illustrate two important digital transformations that the Databricks technology excels at, and we hope will bring exciting results to CMCS. Those are data visualization and machine learning. John will walk through how his team applied Databricks to the subject of neonatal abstinence syndrome and transformed that data to achieve visualization of the issues. Next, John will walk through how his team applied Databricks to the subject of severe maternal morbidity and digitally transformed that data to achieve machine learning to assist in analyzing the issues there. Following John's demo, Jenny Kim of Nuna Health will lead us through our journey from MSIS to TMSIS to why we need the analytic reporting environment for MacBiz that we call AirMac that we are currently implementing. After that, I will then provide the context of how we in DSG believe that MacBiz is delivering business value for our business partners. So, I apologize. Let's get started. John Schmidt is the lead data scientist on our analytic contract with NPR, and John, Jenny, and I collaborate together to translate complex analytic requirements and data needs into the digital transformation and infrastructure required to meet the objectives. I am very grateful for his openness, his support, and most importantly, his willingness to join me today. So please welcome John Schmidt of Mathematica Policy Research.
Thanks very much, Jack. Thanks very much, Jack. So I'm excited to be here and excited to be on the panel. We're going to show you some canned slides here at the very beginning, but I'm very excited to be able to show you a live demo of the Databricks notebook inside the what we're calling the AirMac analytic environment. There have always been limitations in the data and tools available to study national Medicaid and CHIP topics, as opposed to Medicare, where claims and eligibility are administered on shared systems. Medicaid's administered at the state level, and data has to be submitted to CMS on a periodic basis. And in the past, that data has not necessarily been timely in terms of collection and availability at CMS. TMSIS requires states to submit claims and eligibility monthly. And as Kim Brandt told us earlier, TMSIS now includes all states and provides CMS with timely national program data for the first time. Up to now, Medicaid researchers and analysts were also limited in the tools available for visualization and advanced analytics. SAS has always been the primary tool for researchers for analysis, but it has its limitations as well. So there wasn't an easy way to perform computational intensive advanced analytics and produce quality visualizations without exporting data outside of the CMS environment. AirMac, Databricks, and the Databricks notebooks changes that. So CMS asked Mathematica to take AirMac and Databricks for a test run and to design a limited pilot to assess the capabilities against real data looking at real-world issues. So we designed a 3-week effort with a small team that included CMS, Mathematica, Tista, Nuna, and Databricks. And our goals included exercising the available functionality in Databricks notebooks, these being building the visualizations in JavaScript libraries such as D3 and Leaflet, demonstrating Spark-based query performance against large data, implementing machine learning functionality leveraging the Spark analytics engine, and selecting topics that had real-world relevance that could be leveraged to improve patient outcomes. As a constraint, we had about 3 weeks to do the work, we had a small team, and we had very defined goals. So one of the tasks on our MacBiz data analytics contract develops tools for the IAP. The Medicaid Innovation Accelerator Program is a collaboration between CMCS and CMMI. And the goal of the IAP is to improve the healthcare
of Medicaid beneficiaries and to reduce costs by supporting states' ongoing payment and delivery system reforms. The IAP supports state Medicaid agencies to build capacity in key program and functional areas by offering targeted technical support, tool development, and cross-state learning opportunities. One of the IAP focus areas is improving care for Medicaid beneficiaries with complex care needs and high costs. These are beneficiaries who, because of their health or social conditions, are likely to experience high levels of costly but preventable service utilization, and whose patterns and costs are potentially impactable. So within this focus area, CMS has also launched a maternal and infant health initiative to drive improvements in outcomes and reduce the cost of care for women and infants in the Medicaid and CHIP programs. This is really relevant as Medicaid pays for 47% of all births in the United States. So we chose to focus our Databricks pilot in support of this initiative, looking at two areas affecting maternal and infant health, that being neonatal abstinence syndrome, or NAS, and severe maternal morbidity, which I'm referring to as SMM. So for our pilot, we took two parallel tracks, and for both studies, we set out to take national 2016 TMSIS-based data and identify and extract a cohort population to study each group. We then linked that claims cohort to the available TMSIS beneficiary information, and then tied those cohort demographics to an external county-level area health resource file to get further insights into county-level dimensions. Finally, we generated rates of NAS and rates of SMM for multiple dimensions to be able to use in our study. The further goal, as Jack said, of the NAS effort was to create interactive visualizations to explore the different dimensions and geographic distributions of NAS. For the study that focused on the high-risk moms, we set out to use feature selection methods and to isolate important predictor variables, and to use Python machine learning algorithms like random forest to identify important risk factors and to create a predictive model. So I'm going to switch now to a live Databricks environment in AWS to demonstrate the results of the pilot. I will say at this point that the data and the results that I'm showing you were specifically for the pilot. They don't necessarily represent the rigor that we would use for a normal deliverable or external published study. The data you're going to see was really in support of showing the capabilities of the technology. Just 1 second. So what you're seeing here is the actual notebook product itself. And I wanted to show you under the covers a little bit, just to show you that the code is embedded in what's called the Databrick, or the dashboard view that I'm going to show you. Notebooks allows us to easily embed operational code behind the live dashboard view. And for a pilot like this, we were able to easily build self-documenting dashboards that could be displayed as tools for states and CMS to make timely and data-driven decisions. So this functionality also makes it very easy to build a dashboard view that tells a story around the data, and hopefully that's what it'll convey to you. So I'm switching over to the dashboard view. And I'm going to drill down further into our study on neonatal abstinence syndrome. NAS is a condition that can affect newborns who are exposed to opioids during pregnancy, and NAS symptoms occur because of a newborn's drug withdrawal. It can result in longer and costlier hospital stays after birth. Both maternal opioid use and NAS rates have increased steadily over the past 2 decades. There was an estimated 5-fold increase in the rate of babies born with NAS between 2000 and 2012. Every 25 minutes, a baby's born in the US with NAS, and NAS baby hospital stays are 19 times more expensive than stays with babies without NAS. And surprisingly, Medicaid pays for 80% of nationwide NAS costs. So in terms of research methods, we set out to calculate NAS rates by analyzing national TMSIS analytic files for the service year 2016. We created a cohort data set with all newborns. We then identified NAS cases from a specific ICD-10 code and calculated the denominator by counting unique beneficiaries with a live birth or newborn service codes. So what did we find out? So once we calculated the rates in both the state and the county levels, we could visualize the results. Open source Leaflet allows us to easily build a map-based heat map that's drillable. Hovering over each state will show you the rates. For instance, in New York, they had 9.7 per births, or cases of NAS per 1,000 births. But if you focused on a state like West Virginia, the rate was much higher at 89.1. I think it's significant to look at this state map, and in the states that are white are states that either we didn't have data for or had some data quality issues that we didn't include in the pilot. But in terms of TMSIS nationwide data, we were pretty successful at looking at NAS nationwide across the majority of states. So specifically, I can drill down on New Jersey here, and just a second. There we go. New Jersey has 16.6 births, cases of NAS per 1,000 in the state. But you can see by county that rate varies. So in Union County, it's only 5.3, whereas in Gloucester County, you're up to 56.4. So the real NAS story has to be told at the local level, as the hotspots are not consistent across the state. So when we look at overall rates of NAS at the state level, you can see that West Virginia leads the nation with almost 9% of newborns being born with NAS. Maine and Vermont were close behind, and these state findings were in line with findings of a 2013 CDC study using all payer claims data. We also wanted to look to see if there was any distinction between beneficiaries in rural counties versus beneficiaries in urban counties. So we tied to the area resource file and extrapolated the rates. On this graph, you can see the center line for each state representing the actual state rate, with the purple dot being the rates in urban counties and the green dots being the rate in rural counties. And you can see that across states, there's not a consistent pattern of NAS being in either urban or rural, although in some states there does seem to be a pattern within that state. So to wrap up our approach for NAS, we found Medicaid NAS rates that are 2 to 4 times higher than the all-payer NAS rates observed in the CDC study in 2013 using hospital discharge date. And this could be due to a combination of the increase in opioid use in time since 2013, increased provider use of the NAS diagnosis code over time, and the focus of this analysis on the high-risk Medicaid population who might be at higher risk for NAS. So I'm going to swap now over to our second notebook, which focuses on the SMM. Severe maternal morbidity is a general term encompassing a number of conditions that occur during or after delivery and indicate a potentially life-threatening maternal complication. SMM includes obstetric hemorrhage, eclampsia, sepsis, heart attack, amongst other conditions. And the national rate of SMM in 2014 was 144 per 10,000 deliveries. That was an increase of 200% since 1993. There are large health disparities in SMM, with higher rates among non-Hispanic Black women and women whose deliveries are covered by Medicaid. The SMM rate in non-Hispanic Black women was 2.5 times higher than that of non-Hispanic white women. So in looking at this study, we also used 2016 TMSIS-based claims and eligibility data. We identified cases of SMM based on a set of conditions and related codes that were published by the Alliance for Innovation on Maternal Health. As you can see here, the list of conditions that encompass the SMM designation. So what did we find? Similar to what we showed on the NAS side, we visualized the SMM issue on a national map. And here you can see areas of large instances in New York, Michigan, and Tennessee. What we found in the SMM study was that the rates across states were a little tighter than we found in NAS. When we look at the overall state rates, you can see that the 3 states that I mentioned earlier are in the lead. You can also see that the states are fairly tightly grouped. Some areas, such as New England, have the least amount of SMM in the United States. We then wanted to look at age, because age has been shown as a good predictor or variable that contributes. And the TMSIS data bore that out. So you can see here that as the age of the mother increases, especially over age 40, they're much more at risk of having an SMM event. So beyond descriptive statistics, we wanted to take Databricks and Apache Spark and the TMSIS environment out for a spin to try to do some computational intensive modeling. So we wanted to feed in the predictors, the possible predictors of SMM. And since SMM only occurs in 3% of deliveries, there's a class imbalance that makes predictive modeling difficult. I could create a really predictive model that predicts SMM instances with 97% accuracy, but it's going to predict that everybody in the cohort doesn't have SMM because only 3% do, and that doesn't really do me any good. So in order to overcome this problem, we wanted to oversample the SMM population or undersample the healthy births in the data that we feed to the modeling algorithms. And if we do that, we need to make sure that we don't create a situation where we're overfitting the model, where the results might not produce similar results against new data. So to overcome this risk, we used an ensemble approach, feeding bootstrap data into the random forest modeling algorithm, which in itself builds off of an ensemble of decision trees. And in the end, our final model used 40 forests with 2,000 trees per forest and a maximum depth of 5 for the trees in those forests. And I'll tell you what that actually accounted for in a second. So our main goal here was to try to figure out whether TMSIS data and the capabilities within the notebooks and the algorithms in PySpark could result in pulling out the important variables that contribute to SMM. And this is what the model told us. So you can see here the history of cardiac disease, hypertension, general gestational hypertension, obesity, overweightness, but also things like mental health issues like anxiety and depression. And the model also validated the other studies that identified race as a factor. So I think we were pretty successful in having the model identify factors that corresponded with the available literature. So then we took the results of the model that we created and took a look at what they really meant. So the ROC curve here shows the overall accuracy of our final model and how well it functioned in terms of sensitivity in identifying false positives and true positives. And here we achieved an overall 78% prediction accuracy. But we need to look further to see how the model's really performing. So the confusion matrix shows the number of accurate predictions on the top left and the bottom right quadrants. And on the bottom left, we see the number of cases where the delivery resulted in an SMM event, but the model didn't predict it. Those are the false negatives. And on the top right, we have cases where we predicted to have SMM, but it didn't happen. The mother didn't have an SMM event, and that's a false positive. Overall, the model predicted 58% of the SMM cases successfully. Now, why is this? One of the things that we hypothesized is that the majority of moms likely to have SMM events have the predictors that the model identified, but only a minority of those women actually had SMM events at delivery. Conversely, we saw almost 4,000 moms who may not have been classified as high risk going into the delivery room using the predictors in the model, but they did have an event. So predictive modeling is frequently used to supplement human resources when those resources are limited in their abilities to manually investigate each possible case. A model like this one could be used to identify the mothers most at risk for SMM, and maybe to use that information to make sure that they're getting the appropriate prenatal care to reduce the actual SMM episodes. We only had about 6 days to do our modeling, and while we had, I think, promising results, we feel like there's a long way and a lot of opportunity for us to dig deeper and get more insights. And we look forward to that opportunity when the AirMac environment goes live. The SMM rate in Medicaid in 2016, we found, was 2.2 times higher than the all-payer SMM rate estimated by the CDC in 2014. And these higher rates are likely to due to the focus of this analysis on the higher risk Medicaid population. In the model, the top predictors of SMM aligned with all the existing clinical literature that we found. And as a disclaimer, the preliminary results of this pilot were not subject to the usual rigor that we apply on a formal deliverable or a published study. But that said, overall, TMSIS is proving that it can be an important new data source for monitoring state trends in SMM and NAS rates and for evaluating prevention efforts. So to wrap up, the pilot demonstrated that a small team unfamiliar with Databricks could use it against timely and complete TMSIS data to quickly produce results that were validated against external sources. And moving forward, these tools and data can be leveraged to improve patient outcomes, inform policy, and reduce program costs. Jenny Kim's here to talk more about how this environment has been architected to facilitate these capabilities.
Thank you, John, and thank you, Jack, for the opportunity to present here today. I'm a solutions architect for Tista Nuna for both the AirMac and TMSIS projects, and as such, this presentation will largely be from the technical lens on how we built AirMac to foster collaboration and agile data analytics, and in turn, accelerate the data analytics lifecycle. So I'm going to start with a little bit of table setting here because many of the key design principles and goals in building AIRMAC were formed from our learnings and takeaways in building TMSIS. And before TMSIS, there was MSIS. For over 30 years, it was the only centralized repository of Medicaid claims, eligibility, and enrollment data from the states. And it was built on a mainframe-based architecture that received 51 data streams from the states. Unfortunately, running any sort of analytics on the MSIS data was extremely cumbersome. Historically, quarterly data was submitted to CMS, often then going through a series of edits to properly adjust all claims, and then transformed into a research-ready extract called MAX files before finally being made available to researchers through a CMS data portal. And this long data journey meant that MSIS data had a 2 to 3 year lag before it was even available for analysis. So while MSIS was impressively reliable, it really couldn't support the timely and accurate analysis that CMS needed to perform for program monitoring and oversight. Fast forward to 2016, and TMSIS replaces MSIS and its mainframe architecture with a cloud-native system hosted on AWS with horizontally scaling processing on Elastic MapReduce or EMR, highly available, cheap storage on S3, and an operational data warehouse for querying process data in Redshift. TMSIS applies thousands of automated business rules to monitor data quality and ensure standardized data streams. And it allows states to monitor their data as it's processed and receive real-time feedback about errors so that they can quickly address and fix data issues as they occur. After processing, the data is stored long-term in S3, but the most recent data is made available in the Redshift database, which provides query access to the data. Now, Redshift was intended for operational use, so that TMSIS users could quickly examine the clean data and the validation output. However, because CMS's research users were so eager to get analytic access to the TMSIS data, we also ended up providing provisional analytic access to Redshift so that these users could gain access to the data via BI tools like SAS and MicroStrategy for analytic purposes. So one of the first lessons that we learned from TMSIS is that there's an enormous demand for clean, current, and complete TMSIS or Medicaid data. We also learned that there was also considerable interest in combining or integrating Medicaid data with other data sources and public data sets, like in the case of the Area Health Resources file for a richer analysis. Secondly, we learned that while AWS in the cloud provided us with cheap, scalable, and reliable processing and storage for TMSIS, we really needed to push this model even further for our analytic users. Redshift is designed to support hefty SQL workloads, but at the growing scale of TMSIS data, even simple aggregations running in this multi-tenant cluster that also has to support ETL and other operational workloads, we've had to resize our production cluster 4 times in the last 2 years alone just to keep up with demand. And in fact, we're still seeing occasional utilization spikes in our current 24-node, nearly 400 terabyte cluster several times a week. And unfortunately, with this type of traditional shared and persistent data warehouse, while our steady state utilization is generally well under half the capacity of the cluster, we have to plan and size for the occasional peak loads, even though 90% of the time we don't need those extra compute resources. So the ultimate replacement for the analytic data warehouse really needed to push the elasticity and the pay-as-you-go cloud model even further. Finally, while TMSIS did provide timely and accurate data, the analytic development process still seemed lengthy and unwieldy. And when we stepped back, we realized that this inefficiency really came down to the gap that we had between the data analytics team that was developing data products and the engineering team that ultimately operationalized those products. The data analytics team was using their own tools and technologies in a sandbox environment, of course, making assumptions based on that data and environment, and then throwing their code over the wall to the engineering team to productionalize using a different platform and technologies, and inevitably running into issues with the logic conversion and against the production data. And this bifurcation and constant back and forth handoff ultimately delays the time to market for data insights and data products. So how much better would it be if instead the data scientists and engineers could work side by side on a unified platform where they can quickly and easily test and iterate on hypotheses on the actual data with the same tools and technologies. And this is the core vision and value of AirMac, which is to offer a platform that not only centralizes all this data for MacBiz, but also supports an adaptive, collaborative, and unified data analytics platform that can scale against massive volumes of data and users, ultimately allowing CMS to not only be able to ask more questions from their data, but also able to get the answers that they need to inform policy with much faster speed of delivery. So to pull this off, we need to make the data instantly, cheaply, and securely available for a variety of use cases, many of which we can't even predict now. This means liberating access to the data and breaking down data silos, and providing timely and accessible data with self-service tools to users. We also need to rapidly and efficiently scale to the needs of the business, and even better, auto-scale resources automatically for business-critical functions. And finally, we need an environment that facilitates collaborative and cooperative data science between entities, with open and verifiable methodologies, and reducing or eliminating the prototype to product handoff. So how does the cloud enable us to offer this flexibility and scalability? Well, we're well aware now of how AWS's managed services alleviates the DevOps and the infrastructure management burden, so that it's not just trivial to provision and deploy services, but also to scale them, using auto-scaling features where we can set policies to allow resources to automatically resize to the actual need. We can also leverage the security investments made by AWS and benefit from the economies of scale on a massive shared infrastructure. AWS gives us cost efficiencies by allowing us to pay for what we use so that we can pay for actual instead of predicted peak usage. And the performance benefits that we gain from elastic scalability and reliability of AWS ultimately means a much better end user experience with faster and reliable response times. The way that AirMac is able to achieve cheaper, more flexible, and most importantly, faster and more reliable access to data is based on its data lake architecture. With the data lake, instead of loading prepared data into Redshift before it's available to query, we ingest raw data as is and store it in S3 where it can be directly queried in place without necessitating a data load. For structured tabular data, we optimize for aggregation-heavy analytic workloads by converting the data to Parquet, a column-compressed format. And this gives us great performance boosts for structured data. But again, because all of our data is ultimately sitting in a file system in S3, we can easily support semi-structured and unstructured formats like PDF documents as well. Instead of paying for a massive database that mostly sits idle, we spin up compute clusters as needed, when needed, and we bring the compute to the data, which gives us not just the cost benefits of paying for actual use, but also greater security through workload isolation. We can provision a separate cluster for each use case instead of forcing all workloads to share a single warehouse where all the data resides. This effectively gives us fine-grained control of resources per use case without configuring complex workload queue policies. So the reason that the technology has reached the point where computation is both scalable and fast enough to power ad hoc on-demand analysis over a data lake is because of our computing engine Spark. Spark is an extremely fast in-memory general-purpose processing engine that also includes several APIs to perform all sorts of analysis, from batch to streaming to interactive queries, as well as machine learning and graph processing. Spark supports SQL, Python, R, Scala, and Java, so it's very approachable for programmers and data analysts alike. It's open source and natively supported on AWS's EMR technology, which allows us to use it for fast ingestion and ETL processing. So Spark is the kernel that allows us to run super fast ETL and analytics, but a robust analytics platform is more than just fast processing. It means providing analysts with the self-service tools for running analytics and sharing, and administrators the ability to easily manage data and resources as the business requires without engineering support. And this is why we've chosen Databricks to provide the analytics capabilities for AirMac. Databricks is like an intuitive cluster manager and data science workbench built on Spark in one unified platform. And best of all, it runs on our own AWS infrastructure, but it provides very simple administrative tools to manage cluster resources and set configurations and policies like auto-scaling policies instantly. This means removing humans from the loop simply to add more resources, i.e. no more work requisitions just to resize a cluster. But the key feature that Databricks offers to truly foster a collaborative, real-time data science ecosystem is the Databricks notebooks. Notebooks are essentially like Google Docs plus BI tools plus a programming IDE all in one. Analysts input and run their code and algorithms step by step, viewing and retaining results along the way, and annotating in plain language what their methodology is and how it works. You effectively tell a story with the flow of code and tables and graphs. It's something that sounds trivial at first, but is really kind of profound at how it enables analysts to find that fingertip feel for the problems and answers. But really the most powerful feature of Databricks notebooks is that now teams can share and collaborate in real time on a notebook with other data scientists and engineers and team members to collaborate on analysis in an open and verifiable manner. And because they're integrated with Spark, you can easily mix and apply not just different programming languages, but different types of analysis, from simple SQL aggregations to regressions, graph algorithms, and machine learning. You can easily merge data from different data sources and in different file formats, and you don't have to switch tools to do so. It's how we achieve actual agility via short iteration cycles and being able to slightly change direction with more feedback and information. This real-time collaboration, coupled with the showing your work nature of notebooks, which utilizes the same code and technology that we would use in production, is what allows us to rapidly implement data analysis in production without necessitating that handoff and conversion. And it ultimately means faster time to delivery for data analytics. This is a high-level depiction of the current state of the AirMac system as it interfaces right now with TMSys and eventually the other pillars of MacBiz, and includes the ingestion, ETL, warehousing functions, as well as the Databricks-powered analytics functions. The future of AirMac will not only involve collection and more access to other data sets and feeds, but also a big expansion of its capabilities and the use cases and data products it'll support. So to summarize, building an agile data-driven system at the scale of Medicaid data means achieving actual agility, efficiency, and performance at scale. Cloud and new big data technologies like Spark and Databricks have allowed us to now reach the inflection point where we can cheaply and efficiently break down information in data silos, empower teams to explore data, and reduce the effort and thus the speed of delivery for those insights to drive decisions and outcomes. And this is how AirMac is able to foster an agile, collaborative culture that can quickly and constantly iterate on data analysis and rapidly pour those insights and data assets back into the business of providing better care. Thank you, and I will now hand it back over to Jack.
Thank you, Jenny. So John showed you a very powerful Databricks demonstration and how we are using the technology to digitally transform Medicaid and CHIP data into patient-centered solutions. And Jenny explained why we need the analytic reporting environment and how it supports what John does and CMCS's ability to develop quality data products. Now, I would like to take a few minutes, or a very short, brief time, and would like to provide a business view of MacBiz with some context on how MacBiz is helping CMCS digitally transform the Medicaid and CHIP data into data products that provide useful and meaningful information about Medicaid and CHIP patients. So this view of MacBiz shows the source of data coming from the sources of data that come from our states and from the states and pharmaceuticals. And yes, with TMSIS, we are now 50 states, DC and Puerto Rico. We are very proud and happy about that. So the data is coming from the states and pharmaceuticals and it's exchanged between these sources and the various business systems, the MacBiz business systems, including the legacy systems, TMSIS, MacPro, MDP, and MacFin. These operational systems perform appropriate business rules that verify and validate the data in each system. The data is then located in the analytic reporting environment for MacBiz, which utilizes several tools such as S3, Redshift, and Databricks, as example, to create various data products such as our data marts, TMSIS analytic files, data quality reports, and valids files, or, as you just saw, data visualization and machine learning products to help analyze specific health issues. These products are for consumption by CMCS and downstream users. The operational systems and the analytic reporting environment, which is in there on the left side there, are generally used to support CMCS's ability to support program oversight. However, data is shared and disseminated to the IDR and CCW for broader consumption across the CMS community. All of the data is accessible by SaaS and MicroStrategy business intelligence tools for the CMS internal community, as well as an approved external community with approved DUAs. The public can access other data products being built, such as data marts and the new state scorecard, which is recently released by the Office of Administration, and these products are available through the internet. There will also be a secure API to support the Lifeline project for FCC to confirm Medicaid beneficiary eligibility to providers from a public setting. Finally, the demo that John provided used TMSIS data stored in AirMac using the Databricks notebook to develop two data products that ultimately many CMS data scientists could share. So that concludes our presentation today, and I hope that we were able to show you what MacBiz is, why we are building the analytic reporting environment, and how CMCS is building useful and meaningful data products that deliver patient-centered solutions. So thank you very much for holding up your lunch. Very sorry about that. For those who wish to stay and ask questions, I'm sure we'd be happy to entertain it. For those who want to go to lunch, help yourselves, okay? But thank you.
Thank you, Jack. We actually have two questions that have come in through WooFoo. We're going to go ahead and flash, well, as we get those flashed up, the first question is there any business impact around the cost of getting data out?
Is there any business impact to the cost? I would say I don't believe there's a high impact. We find that the cost of transferring data from AWS is not expensive. I know that that's been an issue for others have made similar statements. We're not exactly sure. We've been told from GDIT it costs less than $1,000 to move 25 terabytes of data out of AWS. So you can move a petabyte pretty cheaply.
Great, thank you. And then the second question was, how do you foresee the new TMSIS Databricks environment, TMSIS, excuse me, and its technological changes impacting opportunities to support the broader program.
We're very excited. As the quality and completion of the data coming in to MacBiz as a whole, not just TMSIS, but MacPro, MDP, and MacBin, we'll be able to do much more of a 360-degree view of our program, and we'll be sharing that with the rest of the agency because there's obviously a big tie-in between duals and other costs that are they're common themes on the health perspective. So we will be making our data available for the rest of the agency, certainly.
Wonderful. Great. Thank you so much.
Thank you.
Cheers.
Thanks, everyone.
Thank you all. All right. Very quickly, for the handful of you that I do have left, I have 3 quick announcements. The first, there was a laptop left at security, so check to see if you have yours. If not, it's at security. Second, there's a farmer's market that you may like to visit over lunch, but keep in mind from a timing perspective, you'll need to come back through security after you visit the farmer's market for lunch, and we will be back in this room at 1 o'clock with the Executive Roundtable. Excuse me, there's one more presentation and then the Executive Roundtable. And last but not least, presentations as well as the Q&A transcript from WUFU will be available after the conference, and we'll have more details on that later. Enjoy your lunch. We'll see you back at 1 o'clock. Thank you.